You and a very big hello and a good day to all of you. I'm Dr. Swati, one of your mentors in Study Medic, and a very warm welcome to all on the second day of 10-day risk prevention series. So hope you all enjoyed yesterday's session of maternal medicine. So in continuation to that, today is day two, or in fact part two of the same module, maternal medicine, as it is a huge one and contains a lot of topics. So I will be covering the remaining ones. So yes, let's take you forward. So before starting anything, I always suggest that please start with a positive mindset. Why? Because it turns obstacles into opportunities and challenges into growth. So with this positivity, let's come to today's agenda. So basically, we will be covering today cardiorespiratory and hematology topics. These. Then comes the renal, hepatic, and autoimmune, the other system, from which many questions are asked, of course, because autoimmune is, a personal favorite of RCOG people. Neuro and mental health, epilepsy, migraine, headache in pregnancy. All of you must be well aware that there are a lot of questions pertaining to this. Then acute emergencies, another hot favorite, comprising of sepsis, anaphylaxis, maternal collapse. Topics like these are also very frequently asked. Then comes the topic related to some special situations and pregnancy in some complex social factor situations, breast cancer, domestic violence, topics like that we will just touch through. And at last, we will be dealing with some closing pearls, recall traps, some questions, of course. In between, we will be emphasizing on the most important topics, the most important takeaways, the most important pearls, in fact, which you don't have to ever forget in examination. Okay, so to start with, let's go through just a few master anchor topics. Like these, you don't have to forget at any cost. Cardiac disease remains the MBR race top indirect cause of maternal death. Okay, so MBR race tells us about the statistics and means related to maternal deaths, the important causes. So in that, the topmost indirect cause of maternal death remains cardiac disease. Then another very important, not to be left point is any condition, cardiac condition, which is classified as WHO class 4. Always pregnancy has to be strictly avoided in that. Then another very important thing, sepsis 6. All of you must be well aware of the word sepsis 6 and things to be covered within the first hour of the patient presentation. So it comprises of these 6 things. Please be very clear with this. We have to give oxygen, give IV antibiotics, give IV fluids, and we have to send the sample for cultures, lactate, and monitor the urine output. So these are very important topics. Then comes another very important topic, that is epilepsy. The preferred anti-epileptic drugs are always lamotrigine and levetiracetam. They are the safe ones. And sodium valproate is a drug which is quite teratogenic and hence to be avoided as far as possible. Now, a quick go through the topic weightage. Actually, this slide basically deals with what percentage of questions are asked from which topic mostly. As you can see, renal, hepatic, and autoimmune comprise approximately 24%, means a lot of questions are asked. Especially autoimmune is very, very important. Then comes cardiorespiratory hematology. Quite a lot of questions are asked from cardiac disease, asthma, of course. Then emergencies, as we already emphasized, that sepsis, topics like maternal collapse, anaphylaxis, amniotic fluid embolism are a hot favorite. Followed by neuro and mental health disorders, complex social factors. These all hold quite a lot of weightage in your papers. Now, coming to another very important slide related to UK maternal mortality. The vital statistics. Let's go through some important numbers. Actually, this number is quite important. It's according to MBR Race UK 2025, which deals with data between 2021 to 23. The maternal mortality rate in UK is currently approximately 12.8 per 100,000 maternities. This shows a slight fall from the earlier number, which was between 2020 to 22. It was around 13.5. Now it has fallen down to 12.82, but still it's quite elevated. And quite a lot of actions are based towards reducing this. Another very important part is what is direct cause and what is indirect cause of maternal death. So, as most of you must be knowing, pregnancy specific cause, that is direct cause, is anything which has happened because of the pregnant state itself directly. So, the top most five direct causes are: the topmost remains thrombosis and thromboembolism, that is blood clots. VTE, pulmonary embolism, remains the topmost direct cause of maternal death, followed by obstetric hemorrhage, hypertensive disorders like preeclampsia, eclampsia, hypertension, amniotic fluid embolism, and early pregnancy deaths, especially related to ectopic or sepsis somehow. Then comes the indirect causes. Now, the indirect causes are those which were already there in the lady, that is, they were pre-existing causes or coincidental causes, but were aggravated by her pregnant state. So, the top five indirect causes of death, the topmost cause remains cardiac disease, which is a leading indirect cause of death. And in fact, also remember the overall cause of maternal death, the topmost cause remains cardiac disease, followed by COVID-19, this trinium particularly, neurological, epilepsy and stroke, followed by another very, very important cause, that is psychiatric or suicide. Now, the postpartum psychosis condition or depression condition often leads to lady committing suicide. So this remains top late cause of indirect maternal death. Now, we will have a look on what is late also, followed by sepsis and malignancy. Now, what is maternal death and what is late maternal death? Any death which is happening during pregnancy or within 42 days or 6 weeks of pregnancy termination, of the end of pregnancy, is a maternal death. Whereas any maternal death which is happening after 43 days, means after 6 weeks, up till 1 year after end of pregnancy, but has got a correlation with pregnancy, is late maternal death. Okay, so the topmost cause of late maternal death is suicide. This is again very important, and please do remember this, don't forget. Now let's start with cardiorespiratory and hematology topics. So firstly, I would like to take you through the WHO maternal cardiovascular risk classification. Now, this is very commonly asked in any SBA related to cardiac questions. You need to be very clear in your mind that the cardiac condition which the lady is suffering with, whether it is class 1, 2, 3 or 4. Now, what is class 1? In which, as such, there is no detectable rise in maternal mortality, and there is either no or a very mild increase in morbidity. Okay, so it's not affecting much the pregnant condition of the lady. Uncomplicated mild PS, mild regurgitation things like MR and AR, repaired ASD and BSD. These are mild conditions and can be classified as class 1. Local hospital care setting is sufficient in such ladies. Then comes slightly higher class, that is class 2, where there is small increase in mortality rate and a moderate increase in morbidity rates. For example, repaired ASD-VSD was here, but here unoperated ASD-VSD fall in category or class 2. Also repaired TOF, that is tetralogy of Fallot. This again falls in class 2. So again, the care setting remains the same, local hospital, but slight increase in morbidity is there. Then comes few conditions which may fall in class 2 or may fall in class 3, depending on NYHA status of the lady, depending on how severe the condition is and how well the lady is able to cope up with her condition. So this leads to a moderate increase in both the mortality and morbidity of the lady. Mild left ventricular impairment, hypertrophic cardiomyopathy, repaired coarctation, and Marfan syndrome without any aortic dilatation. So this may be classified as 2 or 3, depending on the particular disease condition, how it is faring. They need to be referred to a hospital setup where multidisciplinary input can be taken. Then comes slightly higher, class 3, where there is significant increase in mortality plus severe morbidity increase is there. For example, condition like mechanical valve, systemic right ventricle, Fontan's disease, cyanotic disease, and Marfan syndrome, where aortic dilatation is less than 45 mm. Aortic dilatation is there, but less than 45 mm. Here, it is very necessary to refer the lady to specialist pregnancy cardiac center where continuous multidisciplinary input is available. So that at every visit, cardiac inputs can be given. Last comes class 4. This, in fact, I would say you need to know very, very well, because here the risk of mortality is quite high, morbidity is quite high, and pregnancy is a strict no, contraindicated here. Okay, so the conditions which fall here are pulmonary hypertension. You might not remember these, but it's very essential to remember these. Okay, guys, please stop scribbling on the screen. Pulmonary hypertension, severe left ventricular dysfunction, where current ejection fraction is less than 30%. Pregnancy is a strict no. Previous peripartum cardiomyopathy with residual disease, severe MS and AS, and Marfan's with aortic dilatation more than 45 mm. All these conditions, please immediately tick on the option that pregnancy is contraindicated or counsel her for the termination of pregnancy, because if pregnancy continues, it will lead to severe increase in the risk of mortality. But if in any case the lady is not ready to get the pregnancy terminated, then expert center care is required. Very close monitoring is required. Okay, so please remember these conditions very, very well. Now let's come to, if any pregnant lady comes to you with cardiac disease and either she is planning pregnancy or is pregnant, what all we will do, the main things. MDT input, first of all, is very much needed from cardiology, obstetrics, and later on anesthesia. First of all, pre-pregnancy assessment. Now, you need to know the baseline cardiac status of the lady. So you need to carry out some investigations. These comprise mainly of ECG, echo, and exercise test. Okay, and categorize the condition of the lady, whether she is WHO class 1, 2, 3, or 4. If suppose she is class 4, try to counsel her against pregnancy. All right. Then review her drugs. On whatever drugs she is, you need to know. If she is on ACE inhibitors or angiotensin receptor blockers or spironolactone, that is mineralocorticosteroid antagonists, then you need to stop these drugs because they are not safe in pregnancy. Then if she is having mechanical valve and she is taking warfarin, try to switch it to low molecular weight heparin, which is safer. Regarding folic acid, routine folic acid dose you can continue, but if in case she is on anti-epileptics or otherwise she is on warfarin or at high risk of embryopathy otherwise, 5 mg can be given, depending, you can individualize. Then comes the antenatal visits. MDT clinic visit is must. Echo needs to be carried out in every trimester because you need to be aware of the cardiac status, and even more often if cardiologist advises, especially in severe conditions. Routine antibiotic prophylaxis as such is not recommended for endocarditis. While planning labor or delivery, most can have vaginal birth. It's not necessary that because of the cardiac condition she needs to have a CS. CS is reserved for obstetric indications only, as is with the most of the conditions. And again, to emphasize, cardiac disease remains the top indirect cause of maternal death in UK. We are emphasizing on this a lot so that it sticks to your mind. Recognition, early recognition and early MDT input saves lives. Okay. Now, let's come to another very important condition, that is peripartum cardiomyopathy. What is it? It's a new onset left ventricular systolic dysfunction left ventricle is not functioning, dysfunction, leading to less ejection fraction, the threshold being 45%. Okay, remember this, PPCM, left ventricular ejection systolic dysfunction is there, and ejection fraction reduces to less than 45%, less than or equal to 45%, with no other identifiable cause. And another very characteristic feature is its timing. It mostly develops in the last month of pregnancy and can develop even up to 5 months postpartum. Now, this depends on various pathogenic factors. The risk factors mainly are multiparity, age more than 30, multiple pregnancy, hypertension, African ethnicity. These all ladies may be at an increased risk of peripartum cardiomyopathy. Now, in its pathogenesis, there has been a role of SFLT and also prolactin, as most of you must be knowing. Okay, there is increased production of prolactin. That's why in its treatment, bromocriptine has got a role. Okay, we will come to that. Then in presentation, often the presenting features like shortness of breath, orthopnea, ankle swelling, cough, if they are mild, they may be often mistaken for normal pregnancy symptoms. So it's very necessary to recognize it timely and to be cautious for it developing. For diagnosis making, echo is essential, and also these factors, BNP, NT-proBNP, they are elevated to more than 100 and more than 300 levels. So these both are mainly diagnostic of PPCM. In acute management, you have to manage it just like cardiac failure. First, let's come to the drugs one by one. Diuretics have got a role, definitely. Furosemide and thiazide diuretics, but they are to be given only particularly for the development of edema, for the relief of edema. They are to be given for short term because they might predispose the lady to developing uterine hypoperfusion, maternal hypotension. So we need to give it for very limited amount of time and for only specific indication to relieve the edema. Then come the beta blockers. The role of beta blockers is also significant here. And try to choose the beta blockers of choice. Here is metoprolol. Then is the role of vasodilator. Hydralazine combined with nitrates, they can be given for vasodilatation. As far as she is antenatal, if this condition is developing during pregnancy, try to avoid ACE inhibitors. Clinically, you can consider bromocriptine also. Then comes the role of anticoagulation. Consider, especially if ejection fraction is less than 35%, because these women are at higher risk of developing VTE. Hence, the role of anticoagulation is there. And also, if the lady is being treated with bromocriptine, there is a risk of her developing hypertension and this thrombosis. Hence, again, the role of anticoagulation is significant, especially if her ejection fraction is low or she is being treated with bromocriptine. As far as mode of delivery is concerned, prefer vaginal delivery if she is stable. CS is reserved again only for obstetric indications or rapid deterioration. And of course, if vaginal delivery is not imminent and her condition is not okay, then you can do a cesarean section depending on individualization of the case. Prognosis, 50% cases recover their ejection fractions fully. However, the recurrence risk is quite high, that is 30 to 50% in the next pregnancy. So counseling is very, very important. Because if in case there is residual dysfunction persisting and ejection fraction is less than 50%, try to counsel her to avoid any further pregnancies. Okay, so these are the main points related to PPCM. Now let's have a look at cardiac drugs in pregnancy. What to continue, what to stop, what to switch. So just like we have, white, amber and red. So here also we are having green, that is safe in pregnancy, amber, that is to be used with caution, and red, which is to be strictly avoided. So drugs, labetalol, methyldopa, nifedipine, hydralazine. We know that these are safe antihypertensives in pregnancy. Followed by digoxin, adenosine, means depending on whatever condition we need to give, we can safely give these drugs. Furosemide, especially if pulmonary edema is there, but yes, for short duration. Heparin and LMWH, aspirin low dose, all these are safe. Few drugs you can use, but with caution. For example, beta blockers. Try to use cardioselective beta blockers, okay? Beta blockers have got FGR risk. Then comes amiodarone. It is related to fetal thyroid dysfunction, hence to be used with caution and only if required. Warfarin, prefer only with mechanical valves, and this also has got teratogenicity, so trimester wise you have to avoid. Diuretics lead to volume contraction, hence prolonged use of diuretics, try to avoid. Verapamil and diltiazem are also to be used with caution. Then the drugs which are a strict no and avoid are ACE inhibitors, ARBs, because these, as you know, have got a role on fetal renin-angiotensin-aldosterone system. And hence they might lead to, fetal kidney injury, oligohydramnios, IUGR, and all those things. Then spironolactone, also, if she is on spironolactone, try to stop it or avoid. Statins, relative. You have to select case by case, but as far as possible, avoid. Then are DOACs, that is direct oral anticoagulants. Rivaroxaban, apixaban, dabigatran, try to avoid these drugs. Then comes amlodipine. It has also got a limited data for safety, hence try to avoid giving in pregnancy. So this slide again was very important because often this is asked. Now let's come to another topic, that is asthma in pregnancy. Now, asthma is in fact the most common chronic condition in pregnancy. If you are being asked what is most common chronic condition in pregnancy, it's asthma. And pregnancy alters asthma in unpredictable ways. You, as far have to remember that 1/3 improve, 1/3 worsen, and 1/3 remain unchanged. And if any exacerbations happen, most of them happen in second and third trimester. Okay. Then already you are well aware with that ladder pattern that first you give SABA, then you start with inhaled corticosteroids, then add LABA, then escalate the dose of steroids, then come to oral steroids. So keep that in mind and you can safely continue these drugs in pregnancy. So on whatever drugs she's maintaining stability, try to continue those drugs in pregnancy. In inhaled corticosteroids, budesonide is preferred. In SABA, salbutamol, LABA, even leukotriene antagonists, all drugs you can continue. Also, oral steroids use as a non-pregnant. However, just know that first trimester use might lead to a small increased risk of cleft lip. But if in case you stop and uncontrolled asthma gets worse, try to continue using it. Acute exacerbation might be there during pregnancy. So depending on her oxygen saturation, give her oxygen, nebulized salbutamol or ipratropium you can give, and if necessary, IV hydrocortisone, if needs to be given, you can give. Then comes the condition known as status asthmaticus, which is a severe one. So you have to manage it just like status epilepticus. In fact, here Maxelf also has got a role, IV 2 grams. Other than this, consider IV salbutamol and senior anesthetic input is necessary for managing this status asthmaticus condition. The drugs which you need to avoid are like aspirin, if it is aspirin sensitive asthma earlier. In beta blockers, try to use cardioselective, that is metoprolol, nebivolol, bisoprolol. These beta blockers are preferred instead of non-selective ones like propranolol, which might lead to sudden bronchospasm. Okay. Then labor analgesia, avoid morphine if severe asthma because it might lead to histamine release. The preferred analgesia is epidural. That is the ideal one. Then in postpartum, continue inhalers. They are safe in breastfeeding. If suppose she is severely asthmatic, avoid carboprost. If pulmonary issues are there, you can, pulmonary artery hypertension type thing is there, then you have to avoid ergometrine as well. But especially carboprost is to be avoided, PGF2 alpha, which may lead to sudden bronchospasm. Use oxytocin and misoprostol instead. Then comes sickle cell disease in pregnancy. Well, one of you has written PGF2 alpha. Very nice. Shows you all are listening mode. Thank you. Now let's come to sickle cell disease. It is again a high yield SBA topic. And now instead of GTG, we are following BSH. Now in pre-pregnancy, sickle cell disease and thalassemia are conditions where folate 5 mg is to be started preconceptionally and continued throughout pregnancy. Another important pre-pregnancy counseling part comprises of partner screening. Since it's a genetic condition, you need to know about the partner as well. If partner screening hasn't taken place, offer it right now. If she is on hydroxyurea, try to stop it 3 months before conception, unless and until it is very necessary. In selected cases, you need to continue, but in most of the cases, you need to stop. Then, during her booking visit, you need to carry out few blood tests and few other routine tests, which includes FPC, retic count, LFTs, ferritin, urea electrolytes, urine albumin creatinine ratio, in fact, blood pressure, partner hemoglobin electrophoresis, and in selected cases, echo also. So this all will depend on the current status of the lady, how her sickle cell disease is doing. Then comes antenatal care. Folate 5 mg is to be continued. Vitamin D is to be given in routine doses as advised. Aspirin, since she is at risk of preeclampsia, you have to initiate aspirin from 12 weeks onwards in the dose of 75 to 150 mg and continue it till 36 weeks. You have to stop it at this gestational age to avoid the risk of PPH. Then sickle cell disease is one of the comorbidity, one of the risk factors for thrombosis. So LMWH is also needs to be considered in all sickle cell disease patients. Then in the antenatal chart follow-up of sickle cell disease, you will notice that full blood counts and midstream urine samples for culture and all are being done every 4 weeks. Starting is first at booking it is done, and then from 20 weeks onwards, every 4 weeks they are doing these two investigations. So keep in mind this also. And then growth scans. This you were starting from 20 weeks and doing every 4 weeks, and growth scans from 24 weeks, every 4 weeks you have to keep on doing. Okay. FGR risk. Now vaccinations, pneumococcal, meningococcal, Haemophilus influenzae, annual influenza, penicillin 5 daily means penicillin 5 antibiotic, and the vaccination has to be taken care of. This is again very important aspect, which is common in thalassemia also. Now let's deal with acute painful crisis. If any patient comes to you with acute painful episode, oxygen is necessary, IV fluids need to be given, her pain needs to be dealt with within 30 minutes. We need to give her painkillers. Now, what is safe? PCM and weak opioids can deal with mild pain. For severe pain, you might need to give stronger opioids. But avoid pethidine, avoid NSAIDs, especially after 31 weeks. Okay, NSAIDs prior to 31 weeks is generally safe, but after 31 weeks has got a risk of premature closure of ductus arteriosus. Okay, so avoid NSAIDs after 31 weeks. Incentive spirometry and anticoagulation depending on the condition, how severe acute painful crisis is. All these are the management aspects of acute painful crisis. Now, another very serious thing is acute chest syndrome and acute stroke. All these are complications which the sickle cell disease patient can land to you with. These are emergency conditions and again have to be managed on oxygen. Bronchodilators in acute chest syndrome, bronchodilators need to be given, antibiotics, and start with simple top-up transfusion. If it is early and less severe, generally simple top-up transfusion is sufficient. However, if patient is not responding to this or the condition is severe, exchange transfusion can also be required. In acute stroke, generally exchange transfusion needs to be given. Then transfusion anytime in pregnancy will depend on her condition. If hemoglobin is less than 60 or rapid falling, or before CS sometimes, or if crisis is not responding, then all these cases might require transfusion. Then regarding birth timing, birth is routinely offered between 38 to 40 weeks. Remember this. And patient needs to be taken up on continuous electronic fetal monitoring. She needs to deliver in consultant-led unit, avoid prolonged labor, dehydration, and hypoxia because these might precipitate crisis episodes. So these were the important points in sickle cell disease. Now let's come to anemia in pregnancy. So you need to know these thresholds, again, very, very commonly asked. First trimester, less than 110. Second trimester and third trimester, less than 105. And just a second. Postpartum, less than 100. Okay. So these thresholds in gram per liter are very important for us to remember because below this, the patient is called as anemic and you have to carry out investigations along with iron studies because yes, again, iron deficiency remains the very important cause of anemia and a treatable one. Then, wherever the hemoglobin is falling less than 70 gram per liter, transfusion is to be considered along with specialist input for complete workup. Now, how will you investigate? If we are keeping iron deficiency in mind, we need to carry out some indices to look whether it is microcytic hypochromic anemia. So for that, we will carry out MCV, MCH, MCHC. If MCV is less than 80, that is, it is microcytic, we also carry out ferritin. And if this comes out to be less than 30 microgram per liter, this is taken as a threshold for iron deficiency. And then oral iron therapy is to be initiated in the form of usually ferrous salts are preferred. Ferrous sulfate 200 mg can be given once, twice, or thrice a day, depending on the individual case. Each tablet consists of 65 mg elemental iron. Now, where will you give IV iron? The indications being oral intolerance, non-adherence, if any GI disease is there and she can't be given or iron absorption is can't be absorbed through GI, hemoglobin is very low and the gestation is advanced, in those cases IV iron might be beneficial. However, remember that you have to avoid IV iron in the first trimester. Try to use only in second and third trimester. Now let's come to beta thalassemia, another very, very important. And this again has got BSH now. GTG has been replaced by BSH and very frequently asked. We can divide it into major, intermediate, and trait, that is minor. So major patients are homozygous and are usually transfusion dependent, requiring more than 7 transfusions per year. They are very high risk patients. And cardiac iron overload is the main concern here. You can be asked that what is the main concern in such patients? So cardiac iron overload is the main concern. Intermediate usually require transfusion. They may be non-transfusion dependent, or if they are transfusion dependent, they generally require 7 or less transfusions per year. Severity is variable. Risks like FGR, that is fetal growth restriction and thrombosis remains. Then comes trait. Now, those who carry beta thalassemia trait, they are generally carriers and have mild microcytic anemia. And their hemoglobin electrophoresis reports show this, increased HbA2 more than 3.5%. The risks are not much, but yes, what is very important in them is genetic counseling and partner screening. Of course, partner screening and genetic counseling remains very important in this also. But here also, we need to do at least this. Although they may be asymptomatic, but this needs to be done. Now let's come to what all you will take care of during preconception screening. So as we know, cardiac iron overload was the main concern. So first let's start with cardiac. You need to know of the current cardiac status. So through these investigations, then here comes the role of cardiac T2 MRI to know about the iron overload. Your aim should be that T2 should be more than 20 ms. Cardiac T2 more than 20 ms means minimal iron overload is there. And one more thing, ejection fraction aim should be more than equal to 56%. Then comes liver. Wherever you are talking about iron overload, the next organ which comes to our mind is liver. So you need to know about ferritin levels, liver T2, or R2, Ferri scan. Your target liver iron should be less than 7 mg per gram dry weight. Also, one important thing is gallstones. They are at risk of developing gallstones, so carry out an ultrasound to rule out any gallstones. Then the endocrine glucose tolerance test. Use fructosamine instead of HbA1c. Fructosamine less than 300 should be your target. Thyroid function, bone density through DEXA, vitamin D, red cell antibodies. Then especially if they are transfusion dependent, you need to be aware of their HIV, hepatitis B and hepatitis C status. And especially in splenectomized women, ensure that they are vaccinated, they are on penicillin prophylaxis, and initiate aspirin because splenectomized patients are especially at high risk of thrombosis. So this thrombosis risk lessens if you start them on aspirin. Now, which drugs? Let's come to iron chelation therapy. If they are on iron chelation therapy, just look whether they are on deferriprone or not, or deferasirox or not. If they are on deferriprone or deferasirox, then stop 3 months prior to pregnancy because they are teratogenic, and try to switch them to desferrioxamine. If they are already on desferrioxamine, you can counsel that yes, it's safe. However, in second and third trimester, it's safe. In first trimester, still you need to avoid this also. Then drugs like bisphosphonates, ACE inhibitors, ARBs, you need to stop. And folic acid, as we discussed in sickle cell disease, 5 mg needs to be started 3 months pre-conception and need to be continued throughout pregnancy. Coming to thalassemia antenatal, intrapartum and postnatal management. Now, in booking, you need to carry out a viability scan between 7 to 9 weeks, review their chelator therapy. Folate 5 mg you need to continue throughout. Aspirin you need to start again from 12 weeks. They might be at risk of preeclampsia. Then, if both partners are carriers, you need to offer them prenatal diagnosis and VTE risk assessment is to be done. These are the main aspects which you will take care at booking. Coming to antenatal visits, monthly you will advise until 28 weeks, after which you will call every 2 weeks, that is fortnightly. Regarding scans, again serial growth scans every 4 weeks from 24 week onwards because of FGR risk. Then cardiac review. See, minimal iron cardiac T2 more than 20 ms was a requirement, means it was our aim. In transfusion-dependent patients, if this is okay, then still you need to have a specialist cardiology input at 28 weeks. Note that cardiac MRI is safe in pregnancy. Okay. Then regarding restarting chelation during pregnancy, when will you start? If suppose T2 is less than 10 ms, that is, she is at high decompensation risk, cardiac T2 is less than 10 ms, then you need to start her on low-dose subcutaneous desferrioxamine, 20 mg per kg per day for 4 to 5 days every week, starting from 20 to 24 weeks. Or if there is severe liver iron overload, then also you may need to start desferrioxamine. So this is the indication to restart chelation therapy. Now coming to another very important aspect, that is aspirin and low molecular weight. So aspirin you have to start anyways. If suppose she is splenectomized or platelet count is more than 600, then they are especially at high risk of thrombosis. Hence, you will start her on low molecular weight heparin as well. If any of these is there, you will start her on low molecular weight heparin. Any admission, if occurring, they need to be covered with low molecular weight heparin. And even otherwise, if other risk factors are there or on VTE risk assessment, you think she needs, then consider LMWH from 28 weeks up till 6 weeks postpartum. Okay. Then transfusion target. If any time she requires transfusion, maintain pre-transfusion hemoglobin more than equal to 100 gram per liter. Avoid giving any empirical iron. Okay. Then intrapartum, during labor in transfusion-dependent patients, give IV desferrioxamine 2 grams over 24 hours during labor. She needs to be on continuous CTG, and active management of third stage of labor is a must. Then mode of birth, vaginal, unless any obstetric indication is there again. Thalassemia itself is not a cesarean section indication. Regarding postnatal, breastfeeding is safe. One thing again you need to note that desferrioxamine can be given during breastfeeding because it's not orally absorbed. Hence, it is absolutely safe to breastfeed even if the lady is on desferrioxamine. Okay. So again, these are exam anchors. Just go through these. Liver iron target is less than, already we have dealt with this. Okay. Fructosamine target is less than 300 nanomole per liter. So now just a quick recapitulation regarding cardiorespiratory and hematology slides. Never continue ACE inhibitors, ARBs and spironolactone in pregnancy. Never use IV iron in first trimester. Never give iron supplements in thalassemia if there is no deficiency has been elucidated. Never use ergometrine or carboprost in severe asthma because of the risk of bronchospasm. Never use pethidine in sickle crisis because of seizure risk. Never allow pregnancy in pulmonary hypertension or any other WHO class 4 disease, cardiac disease. Always use modified WHO classification for cardiac risk. First stratify the disease. Always use folic acid 5 mg in sickle cell disease, thalassemia, or if she is at high risk of embryopathy on warfarin. Sickle and thalassemia, keep these in mind. Folic acid, aspirin, thromboprophylaxis, vaccination, and antibiotics. These are very essential. Always do an echo every trimester in significant cardiac disease. Always transfuse if hemoglobin less than 70 or sickle crisis unresponsive. Do an HDU evaluation for 24 to 48 hours postpartum if significant cardiac disease is there. Okay, because cardiac decompensation may occur in this period especially. And also be on the lookout for PPCM. Okay, so hope till now it was clear. Now let's proceed to inherited bleeding disorders, which is again a very important topic, and these three are very, very important. So now let's have a look as to what they are and what you need to do, what all are the risks. So first let's pick up hemophilia A and hemophilia B. Let's do them together because they are very close. Defect here is reduced or absent factor 8. Here is reduced or absent factor 9. Inheritance for both is X-linked recessive. Now in pregnancy, factor 8 rises, but factor 9 stays stable. So this is physiological change which is occurring in pregnancy. Now bleeding risk, carrier may bleed more during procedures, during miscarriage, during delivery. Same is for hemophilia B also. When the factor levels need to be checked, you should check it at booking, before any procedure, and then in third trimester. Target, factor 8 levels should be at least more than equal to 0.5, and 9 levels also should be more than equal to 0.5. And if you are treating, aim to achieve factor level of 1. First line treatment. Now let's come to treatment part. So look, if factor level is more than 0.5, tranexamic acid alone may suffice. If it is less than 0.5, then give tranexamic acid along with actual treatment, which might be in the form of DDAVP, that is desmopressin, or if needed, recombinant factor 8. Okay. Here, DDAVP does not work in hemophilia B, so recombinant factor 9 needs to be given to cover the procedures, especially if factor levels are less than 0.5. Remember, above 0.5, tranexamic acid can work alone. Below 0.5, you need to give treatment, especially if you are doing any procedure, to cover up any procedure. Then comes very important prenatal diagnosis. Now, all carriers of severe hemophilia, whether it is A or B, they should be offered fetal sex determination through CFF DNA between 9 to 11 weeks. Then to male fetus, if the fetus is found to be male, CVS, that is chorionic villus sampling, is to be offered between 11 to 14 weeks. If these all haven't happened before, even third trimester amniocentesis can be offered later on. Also, all carriers of severe hemophilia try to offer pre-implantation genetic diagnosis also you can offer. Here for hemophilia B, again the things are same. Now let's come to von Willebrand disease. Now von Willebrand disease can be of several types. Types 1, 2, 3, even type 2 has got classes, categories. So here what happens, von Willebrand factor is either less in amount, as in type 1, mild quantitative deficiency is there, type 3, severe quantitative deficiency is there, or as in type 2, qualitative VWF defect may be there. Okay. The difference in inheritance pattern is that it is not X-linked recessive. It is either autosomal dominant or autosomal recessive. Now in pregnancy, what happens physiologically? VWF rises in type 1, but not in type 2 and 3. That's why type 1 is considered mild. Bleeding risk is high in antepartum period also, and the risk of primary and secondary PPH also remains. Then what you have to check? You have to check the levels, VWF antigen, the activity levels, factor 8, when? Again at these times only. At booking, before any procedure, and before in third trimester. Target to cover is factor 8 and VWF ristocetin cofactor activity should be more than 0.5. And if you are treating, aim to achieve a level of 1. Here again, desmopressin has got a role. If patient is responsive, good. Otherwise, you can also give VWF factor 8 concentrate. Regarding prenatal diagnosis, genetic counseling is to be done, and also regarding the genetic risk of variable penetrance is also to be explained. So that's about VWD. Next comes factor 11 deficiency. Defect, reduced factor 11 levels. Inheritance is autosomal, common in Ashkenazi Jews. In pregnancy, factor 11 as such does not rise. Factor 9 stays stable. Factor 11 also does not rise. Here, there is poor level and bleed correlation. Means it's not that if levels are less, then bleeding will be more. The correlation is poor. Spontaneous bleeding is also rare. Levels are again done at booking, pre-procedure and third trimester. Target to cover will be guided by the specialist. Tranexamic acid remains the mainstay. Plus minus FFP, factor 11 concentrate can be given if required. In prenatal diagnosis, genetic counseling holds importance. So that's in brief regarding hemophilia A, B, VWD and factor 11 deficiency. Now let's come to what you have to actually do during pregnancy, intrapartum and all. One very important aspect is regarding DDAVP. Few things you have to keep in mind. DDAVP, that is desmopressin, raises factor 8 and VWF levels. When you are giving this, you have to restrict fluids to 1 liter in 24 hours. Remember this. This is very important because of the risk of hyponatremia. Also, you have to avoid an preeclampsia. Then another important thing is that in type 2B VWD, if you are giving DDAVP, then it may cause thrombocytopenia. Okay. So if in type 2B VWD you are giving DDAVP, please be on the lookout that it might lead to thrombocytopenia. Regarding mode and timing of delivery, again, it's not solely an indication for cesarean section. Obstetric indications will guide, and spontaneous vaginal delivery is preferred. If elective cesarean section is chosen, then do it at 39 weeks. When can you choose planned LSCS? You can discuss about planned LSCS for affected or unknown males, especially in severe hemophilia cases. If the lady is having severe hemophilia and you know that it's a male which is who is affected or the status is unknown, then of course, to keep invasive things to minimum, you can choose elective LSCS if to be done you can do at 39 weeks. Avoid in at-risk fetus, things like fetal blood sampling, fetal scalp electrode, instrumental deliveries, especially mid-cavity forceps and ventouse you have to avoid. Avoid ECV in affected and at-risk male fetus and these severe conditions like VWD type 2 and 3. Avoid these things. Regarding neuraxial block, you need the factor levels to be more than 0.5. Type 1 VWD, if normalized, okay. Type 2N needs factor 8 to be more than 0.5. And type 3 VWD, since it is severe quantitative deficiency, so try not to give neuraxial block in type 3 VWD cases. Hemostatic cover, DDAVP or factor concentrate to peak 1 near delivery. Tranexamic acid can be given as adjunct or sole therapy as discussed. And type 2 VWD, since DDAVP was causing thrombocytopenia here, they might require platelet transfusion. Then regarding PPH prevention, AMTSL is to be followed, active management of third stage of labor, because you need to avoid PPH at any cost. Maintain factor level more than 0.5 for at least 3 days or more in vaginal delivery cases, or for 5 days or more, especially if she has undergone any instrumental delivery or cesarean section. So this again is very important. And also keep on giving tranexamic acid until lochia is minimal. So till the time she is bleeding after vaginal delivery or cesarean section and lochia is coming, tranexamic acid can be continued. Regarding cord sampling in neonate, for male babies of hemophilia carriers, do a cord sampling, but not required in female babies. VWF cord sample can be taken if VWD type 2 or 3 because they are severe ones. Vitamin K, try to give oral, not IM. And in severe to moderate cases, you should in fact prescribe cranial ultrasound for baby to rule out any intracranial hemorrhage. Never use DDAVP in preeclampsia. Never try these things, ventouse or mid-cavity forceps, fetal scalp electrode and fetal blood sampling in at-risk males. And never prefer IM injections, especially if factor levels are less than 0.5. Okay, these are nevers which you have to remember. Top SBA pearls, factor 8 rises, but factor 9 and 11 do not during pregnancy physiologically. DDAVP might cause hyponatremia, hence you have to restrict fluids. Type 2B, VWD, if DDAVP given, thrombocytopenia is common, hence platelet infusion might be required. Post-CS, for more than 5 days, you have to maintain factor levels more than 0.5 and for vaginal delivery more than 3 days. And VWD has got secondary PPH risk. That's regarding inherited bleeding disorders. Quick review. Now let's come to another very important topic, that is thrombocytopenia in pregnancy. Now quickly, if we look at the first and foremost cause, it's gestational thrombocytopenia. Why? Because there is physiological dilution and accelerated destruction of the platelets. Diagnostic feature being, see, any kind of gestational thrombocytopenia, benign diagnosis you have to make only after ruling out the serious causes. So here, usually gestational thrombocytopenia will arise in third trimester. The platelets won't be too low. They will be mostly above 70 and it's an incidental finding. Then immune thrombocytopenic purpura, the next important cause, it's an immune destruction of the platelets along with suppressed production, and this is diagnosis of exclusion. Here, no specific test as such is there which can lead to diagnosis, but other causes if not there, mostly it's ITP. Then comes another important entity, that is an HUS. Thrombotic thrombocytopenic purpura and hemolytic uremic syndrome. The mechanism is peripheral consumption and microthrombi production. Patient is usually unwell, presents with fever, and may have neurological and renal dysfunction. Now, in TTP, mostly there are neurological symptoms. In HUS, mostly there is renal dysfunction. Then come to HELP syndrome, a very, very important entity. HELP syndrome, Again, the mechanism is same, peripheral consumption and microthrombi production. Here, DIC-like picture is very common. Of course, as the name suggests, there will be hemolytic anemia, elevated liver enzymes, that is ALT, bilirubin, LDH, and low platelet count. It may or sometimes may not be accompanied with preeclampsia. Okay. Then comes hereditary thrombocytopenia, where there is underproduction of platelets in the bone marrow itself. The diagnostic features being family history, abnormal platelet counts. Pseudothrombocytopenia might be an lab artifact, where you generally see platelet clumps on the blood film. Viral infection, some drugs like heparin may cause thrombocytopenia. Leukemia or lymphoma might be another important hidden cause. Here, bone marrow infiltration takes place, hence platelets are less. Here, enlarged liver, spleen, lymph nodes, all features will be there. So these are some important causes of thrombocytopenia, which you should keep in mind. Now, there is a very beautiful table in one of the talks, which differentiates between TTP, HUS, HELP, and preeclampsia. Just have a quick look. Onset, TTP can occur anytime, including postpartum. HUS is very common in postpartum. HELP syndrome mostly occurs in third trimester. Preeclampsia can occur anytime after 20 weeks, mostly in third trimester. Hypertension, in preeclampsia, of course, there is hypertension. In HELP syndrome, hypertension may or may not be there. In TTP and HUS, hypertension as such is not accompanying unless and until it's because of some other cause. Then microangiopathic hemolytic anemia occurs in TTP, HUS, and HELP. Thrombocytopenia is seen in all. It is significant in TTP and HUS and HELP, not that significant in preeclampsia alone. DIC is typically seen in HELP syndrome. Liver disease is typically seen in HELP syndrome, as elevated liver enzymes are typical here. In others, it may or may not be there, but in HELP syndrome is typical. Then renal disease is typically seen in HUS, and CNS disease is typically seen in TTP. Okay, so liver disease in HELP, renal disease in HUS, CNS disease in TTP. Management, in HELP syndrome and preeclampsia, you have to deliver along with giving blood products and stabilization. HUS is supportive and TTP plasma exchange. So it's very necessary, because in earlier also question have been asked that you know how to differentiate or what are the cardinal features between TTP, HUS, and HELP. All right, so let's have a quick look at the top SBA pearls. Modified WHO classification, class 4. You have to avoid pregnancy. Again, to recapitulate, cardiac disease is the topmost indirect cause of UK maternal death, according to MBR race. Peripartum cardiomyopathy, new onset LV dysfunction, ejection fraction being less than 45%. Time of onset is either in last month of pregnancy up to 5 months postpartum. Recurrence risk is very high, 30 to 50%. Asthma, the most common chronic condition in pregnancy. Continue whatever drugs she was taking. Avoid carboprost and ergometrine in severe asthma. Sickle cell disease, folate you have to give 5 mg, aspirin 75 mg, thromboprophylaxis, antibiotic, vaccination, and in crisis, IV fluids and opioids, but avoid pethidine. Anemia thresholds, less than 110 in first trimester, less than 105 in T2, T3, that is second and third trimester, less than 100 in postpartum. Ferritin less than 30 means iron deficiency is there. IV iron, avoid in first trimester. Only second, third trimester if in case oral iron fails or absorption issue is there. Okay. So this was the summary. So now let's come to a few questions related to cardiac disease. A 28-year-old woman with mechanical mitral valve. She takes warfarin 5 mg daily and she is planning pregnancy. INR is therapeutic at 3. What's the most appropriate pre-pregnancy advice? Now looking at warfarin, it will immediately come to our mind that she's planning pregnancy. We might need to switch it over. So we will look for options, search for something like that. Continue warfarin throughout pregnancy, we don't think. Switch to LMWH preconception with anti-10A monitoring. This may be a possible answer. Switch to direct oral anticoagulant, rivaroxaban. We studied that it is to be avoided. Continue warfarin only in first trimester. No, warfarin embryopathy is more common in first trimester. Avoid pregnancy entirely. No, that would be too strict on her part. So switch to LMWH preconception with anti-10A monitoring seems to be the correct option. Safer outcomes, fetal outcomes if warfarin more than 5 mg per day. Embryopathy risk is 4 to 10% if dose is more than 5 mg per day. DOACs are contraindicated. Highest embryopathy risk window in first trimester. And avoid pregnancy entirely. No, it's not class 4. So she can be allowed. Next, a 30-year-old Gravida 2 para 1 with hemoglobin sickle cell disease in labor at 38 weeks developed severe bone pain. Temperature is 37.4, SpO2 is 96%, heart rate and BP are these. She is dehydrated. What is the immediate priority? Now she's having acute pain episode. So let's look at the options for the best answer. Pethidine for pain is obviously not advised. IV fluids plus morphine plus oxygen plus thromboprophylaxis seems to be a complete answer. Immediate C-section for this alone doesn't seem feasible. Exchange transfusion immediately not advisable. Oral paracetamol plus ibuprofen might be an answer, but not a complete solution here. So let's have a look. See, at 38 weeks, ibuprofen seems not to be good because it might lead to premature closure of ductus arteriosus. Pethidine increases seizure risk in sickle, so to be avoided. This seems to be a complete answer as it is standard sickle crisis management. Immediate C-section, no obstetric indication, treat the crisis first. Exchange transfusion reserved for acute chest syndrome or unresponsive crisis. And this, as we dealt with, NSAIDs are to be avoided, and oral paracetamol is inadequate analgesia, in fact, for severe wound pain. So, just some scenarios from past papers. Ferritin 35 plus hemoglobin 105 in second trimester. Is it iron deficiency? No. Ferritin more than 30 excludes deficiency, so we have to investigate other cause. Postnatal day 10, new shortness of breath, orthopnea and low ejection fraction 38%. What it can be? Since ejection fraction less than 45%, postnatal day 10, immediately think about PPCM and give ACE inhibitors, diuretics, beta blockers, means whatever treatment for PPCM. ACE inhibitors can be given because now she is postnatal. Sickle cell plus crisis, choose analgesic. Morphine is the preferred one, not pethidine because of seizure risk. Mechanical valve plus 6 weeks pregnant on warfarin. Try to switch her to low molecular weight heparin with anti-10A monitoring. Pulmonary hypertension diagnosed plus 8 weeks pregnant. This is class 4, WHO class 4. Counsel about termination as mortality is around 40%. Severe asthma, third stage PPH, oxytocin you can give. You should avoid ergometrine or carboprost. Beta thalassemia major plus low ferritin, investigate. Iron usually high, hence avoid empirical iron. Okay, in beta thalassemia major cases, if ferritin is coming low, still you need to investigate further. Why? Because usually beta thalassemia major patients are transfusion dependent and hence they are having iron overload. So avoid empirically given iron to them unless and until clear-cut iron deficiency is found out. So again, the same things. Risk stratify, class 4 avoid pregnancy, stop these, echo each trimester in any cardiac disease, PPCM time of onset, cardiac is the top indirect cause of death, asthma 1/3 worsen, 1/3 get better, continue these drugs, acute cases of asthma, O2 nebulization, IV hydrocort are the mainstay, Maxil 5e 2 gram you can give in status asthmaticus and avoid ergometrine and carboprostin severe asthma. Hematology, these thresholds very important. Ferritin less than 30 means iron deficiency. Avoid IV iron in first trimester. Sickle cell, these drugs, no iron in thalassemia without evidence, clear-cut evidence of iron deficiency. And penicillin prophylaxis daily in sickle cell patients. Guys, please stop scribbling on the screen. It's diverting. Okay. All right. So hope the things were clear up till now. Now let's come to the second part, that is renal, hepatic, and autoimmune diseases. Now there is a criteria. Now first let's come to acute kidney injury. Kidney conditions may be acute or may be chronic. So first let's deal with acute kidney injury in pregnancy. According to KDIGO criteria, pregnancy specific causes, KDIGO staging, any acute kidney injury might be stage 1, 2, 3. So if it is stage 1, what happens? Creatinine rises there. 1.5 to 1.9 times rise is there from the baseline, or more than 26.5 or more micromole per liter within 48 hours rises there. Urine output falls to less than 0.5 ml per kg per hour for 6 to 12 hours. In stage 2, there is again a rise in creatinine of 2 to 2.9 times baseline. This reduced urine output stays for 12 hours or more. Whereas in stage 3, creatinine has risen by 3 times or more from the baseline, or it becomes more than equal to 353.6 micromole per liter, or you need to have initiated means in consultation with nephrologist renal replacement therapy. Here, this output is still low, less than 0.3 ml per kg per hour for 24 hours or more, or sometimes patient becomes anuric for 12 hours or more. So this is the KDIGO staging. Just have a rough idea about this. You need to know the pregnancy specific AKI causes. The most common cause of acute kidney injury in pregnancy is preeclampsia and HELLP syndrome. This is very important. Please know this. Next cause is acute fatty liver. Hepatorenal syndrome often occur in correlation. So acute fatty liver might lead to acute kidney injury as well. Then is the sepsis. The focus may be urinary. Chorioamnionitis also might lead to acute kidney injury. In fact, any sepsis can lead to multi-organ dysfunction and hence acute kidney injury. Obstetric hemorrhage and hypovolemia are again very important causes. TTP and HUS, as we went through earlier in the slides, HUS is a cause of renal dysfunction, so might be a cause of acute kidney injury. And postpartum AKI can occur from PPH. It will lead to hypovolemia or DIC as such. So these are the pregnancy-specific AKI causes. The treatment principle, as such, there is no one particular drug for kidney injury. You have to basically treat the underlying cause, maintain fluid balance, that is euvolemia, avoid over-resuscitation, giving over fluids, avoid nephrotoxic drugs, especially NSAIDs and gentamicin. You need to seek an early renal MDT input. Dialysis indications are generally same as non-pregnant. This much is sufficient in acute kidney injury. Now let's come to chronic kidney disease and pregnancy. Now, such patients do have got, whenever they are planning pregnancy, you need to counsel them very well, as their pregnancy outcome depends on their baseline creatinine as well as the blood pressure. So pre-pregnancy creatinine, if less than 125 micromole per liter, there is mild risk. Most pregnancies are successful and there is a small reduction in long-term renal function, but otherwise most things are well. If creatinine levels fall between 125 to 180, then the risk is moderate. 30% rate in acceleration of the CKD condition is there. There are also chances of preeclampsia happening in 40% cases and preterm deliveries in more than 50%. That is approximately 60% cases. Now, third category, more than 180 micromole per liter becomes high-risk pregnancy. with significant CKD progression during pregnancy and afterwards. Hence, it is recommended that if in a CKD patient, pre-pregnancy creatinine is more than 180, consider postponement until transplant occurs. Until the renal condition gets stable through transplant, try to postpone pregnancy. If she has come for pre-pregnancy counseling, of course. If she's on dialysis, counsel her that it's very high risk. Live birth, only 50% cases. Intensify. You can intensify dialysis sittings to more than equal to 36 hours per week. Then comes the scenario of post-transplant patients. In post-transplant patients, already it should be always it should be an MDT decision whether to plan pregnancy or not. This is very important and has been asked repeatedly earlier also. How much time they should wait post-transplant? They should wait at least 1 to 2 years post-transplant to plan pregnancy. They should have a stable creatinine value, preferably less than 125. And renal transplant patients are often on drugs like tacrolimus, azathioprine, mycophenolate mofetil, cyclophosphamide, cyclosporin. So switch to safer drugs. Like tacrolimus and azathioprine are comparatively safe in pregnancy. So try to switch them to these drugs. In antenatal management, the pearl points are: aspirin is to be started. We all know that CKD is a high risk of preeclampsia. You have to initiate aspirin 75 to 150 mg from 12 weeks. Target blood pressure should be less than 140/90. Mostly they are already on antihypertensives to switch to safer ones. So switch the ACE inhibitors and ARBs to labetalol, nifedipine preconception itself. Monitor creatinine levels, albumin creatinine ratio, blood pressure at each visit, and growth scans preferably from 24 weeks because risk of FGR is there. So these are the key points which we have to remember in any patient planning pregnancy or getting pregnant with CKD. Now let's come to another interesting topic, that is intrahepatic cholestasis of pregnancy. See, exam appearance in 80% of recent UK papers, you have found questions from this. So any pruritus, if lady is presenting to you in second and especially in third trimester with pruritus but without any rash, think about obstetric cholestasis. Order for LFTs and bile acids. If bile acids are elevated, 19 micromole per liter or more, then it comes the diagnosis of ICP, that is intrahepatic cholestasis of pregnancy, is confirmed. You can plan further action by peak bile acid level. If no, then most probably it's either gestational pruritus or you have to be on the lookout for other causes. However, don't leave like that. Just repeat again these tests in 1 to 2 weeks if her pruritus is persisting. Might be right now you are not getting, later on bile acids start getting elevated. Then you all are well aware of what you have to do. Mild, moderate, severe. Look at the peak bile acid levels. If they are more than 19 or more, but less than 40, it's mild. So stillbirth risk is same as background. Offer birth at 40 weeks, no earlier indication. You have to keep on doing weekly LFT and bile acids. Okay, weekly, remember. If it falls between 40 to 99, it's moderate. Stillbirth risk, not much, slightly elevated. But you have to offer earlier birth between 38 to 39 weeks. Again, weekly bloods and serial scans are recommended. However, if the peak bile acids are 100 or more, this falls in severe category, severe ICP. Here, stillbirth risk gets significantly elevated, 3 to 4 times that of background risk. So offer an earlier birth, means preterm. 35 to 36 weeks you have to deliver if she is severe ICP. You have to keep on surveying her through weekly bloods, and even you can consider admission if she is an advanced gestational age. Also, here continuous electronic fetal monitoring is advised, and means for severe ICP you have to be cautious. Regarding treatment aspect, ursodeoxycholic acid is not recommended routinely because it has not been found to reduce the level of bile acids. Only it is to be given if pruritus is severe. Otherwise, as such, it is not recommended routinely. Mainly for pruritus, you have to give topical emollients, anti-allergics, chlorpheniramine 4 mg at night, vitamin K if prolonged PT-INR is there, and continuous CTG in labor from active phase you need to do. Because the risk of meconium is high, especially in severe ICP cases. Another aspect regarding recurrence and future pregnancy, the recurrence risk is quite high in next pregnancy. Then avoid estrogen containing contraception, especially if she has got a history of cholestasis getting precipitated with CHC. CHC induced cholestasis if she has had earlier, then especially avoid estrogen containing contraception. She might be at high risk of HCV, so consider screening for HCV. And in long term, it has been found that she might be at increased risk of gallstones. So this is also to be counseled. Now, since she is at risk of recurrence, so in next pregnancy, when she comes to you, along with booking bloods, also do carry out LFT and bile acid, along with booking bloods itself in next pregnancy. Now let's come to acute fatty liver of pregnancy. This again has got a new TOG and is a very important condition because it has got very high morbidity and mortality also. So here you need to know there is a criteria called Swansea criteria, which has got these features, components. If 6 or more features are met, then it is diagnostic of AFLP. Now what are these? Patient may present with vomiting, which is persistent and severe, abdominal pain, especially right upper quadrant or epigastric, polydipsia or polyuria, that is diabetes insipidus features might be there. She may present to you with confusion and drowsiness, indicative of encephalopathy. Bilirubin might be high, especially it is quite high in acute fatty liver of pregnancy, more than 14 micromole per liter. Hypoglycemia, if it is given in millimole per liter, less than 4. Increased urate, leukocytosis. On ultrasound, ascites or bright liver appearance is there. Transaminases, along with bilirubin, transaminases will also be raised. Ammonia might also be raised. Renal impairment might be there. Patient might present with coagulopathy, very high chances. And on biopsy, if by any chance it is carried out, you might notice microvesicular stenosis. It is confirmatory, but actually rarely needed. So if 6 out of these are satisfied, you can make the diagnosis of AFLP. It is very important for us to know the difference between ICP, HELP, and AFLP. First of all, just like in other cases, we were looking at the onset. Onset is usually in second or third trimester in all the three. Pruritus, in ICP, it won't be postpartum, but in HELP or AFLP, it might be even postpartum as well. Pruritus is severe in ICP, absent in these two. BP will be high in HELP only, often, not always. Bile acids are quite high in ICP. ALT, AST will be high in HELP, very high in AFLP. Bilirubin again will be high, might be high in HELP, very high in AFLP. Platelets will be low in HELP, might be normal or slightly low in AFLP. Hypoglycemia is key of AFLP. Usually it is the patients are hypoglycemic. Coagulopathy again is severe. Usually plus minus DIC is there in AFLP. Management, urgent delivery. In HELP and AFLP, you have to deliver urgently. In HELP, you have to again manage, especially if severe preeclampsia is there, myself. In AFLP, ICU admission, multidisciplinary input needs to be there. And in ICP, we have to just give symptomatic treatment, might have to plan early birth in moderate and severe cases. But HELP and AFLP are usually more morbid conditions and require urgent attention. Now let's come to another very interesting topic, that is viral hepatitis and HIV. So here, what is important is vertical transmission focus. Serology is very important. We will be covering in next slide. It's very interesting and I want all of you to pay special attention to hepatitis B serology, which we will be covering later. Now, first let's have a look at hepatitis B, C and HIV. If patient is HBsAg positive, the chances of vertical transmission range between 10 to 90%. It is highest if she is HBeAg positive especially. HBeAg positive means high infectivity. Or viral load if it is high, then also she is at high risk of transmitting the disease vertically to her baby. Management is tenofovir based, especially in third trimester if high viral load. Then hepatitis B immunoglobulin, baby vaccination need to be given within 1 day of baby birth. Then comes hepatitis C. The rate of vertical transmission we can see here is not much. However, if HIV co-infection is there, this risk of vertical transmission increases. Management, this direct antiviral agents that like sofosbuvir and all, you must be aware that now very novel agents have come for hepatitis C treatment, but they are not recommended during pregnancy. These are generally recommended postpartum only. Vaginal birth is fine with hepatitis C, not contraindicated. Now let's come to HIV. Now in HIV, we all know that viral load of 50 as a threshold. If viral load is undetectable, that is less than 50, vertical transmission chances are very less than 1% if she is especially on combined ART. Plus, with proper planning, vertical transmission is quite less. And in such cases, vaginal birth can be offered and baby is offered post-exposure prophylaxis for 4 weeks. Monotherapy is generally sufficient. But if viral load is detectable and more than 50, then vertical transmission becomes high, the rate becomes high. Hence, elective LSCS at 38 to 39 weeks is generally planned for high viral load. And pre-cesarean, generally eiweiß iodine is given and baby is offered triple post-exposure prophylaxis in the form of ZL, zidovudine, lamivudine and nevirapine. So baby is offered triple PEP if viral load is high, single monotherapy sufficient if viral load is undetectable. If HIV happens to be primary in pregnancy, that is for the first time she has become HIV positive in pregnancy. She has become positive in pregnancy, not that she was detected now in pregnancy. If HIV infection has been encountered during pregnancy, then she is at highest risk of vertical transmission. Why? Because it is newly developed in pregnancy. So right now the viral load in new infections is very high and still no antibodies have been formed by the mother. So the risk is high. We have to start her on ART urgently and specialist HIV obstetric clinic needs to be involved. Now, practically, breastfeeding in HIV positive ladies is to be avoided. Try to advise her, counsel her for formula feeding, give her cabergoline lactation suppression and supported choice. If suppose HBV and HIV co-infection are there, then vertical transmission is still higher than either of them has alone. Tenofovir-based card covers both. Okay. So this is in brief regarding hepatitis and HIV. Booking bloods, we all know that in booking bloods, we screen all women for HIV, hepatitis B and syphilis. However, hepatitis C is risk-based only. For example, those who are IV drug abusers or FGM ladies, they are offered hepatitis C screening as well. Otherwise, we routinely screen for HIV and hepatitis B and syphilis. Now, let's come to this hepatitis B serology, the time course of markers. This you must remember that you might remember that we used to study in MRCOG part 1 as well. And here in part 2, again, it is important. There are various antigens and antibodies. So how to interpret their levels? HBsAg, HBeAg, anti-HBc, and anti-HBs. Now let's have a look at them one by one. So first, let's have a look at HBsAg. That is the surface antigen. It is first to appear, and if persists for more than 6 months, then it has become a chronic infection. Okay. So it's first to appear. Remember, this might be asked that which is first to appear. So out of all these, HBsAg is the first to appear. This red one is denoting HBsAg. Then comes HBeAg, that is the purple one. HBeAg or E antigen denotes high infectivity and high vertical risk transmission. Here again, it has got a course similar to HBsAg. It is rising in acute infection and then falling at around 6 months. Then it might persist or not. Next is, now we have started encountering antibodies. These two were antigens. Now comes IgM anti-HBc. So anti-HBc is formed. IgM, of course, acute will be formed first. So IgM anti-HBc is acute infection marker. See, you can see that it has started somewhere just before 4 weeks, rising, and then in window period, it's quite high. Here we look at HBsAg and HBeAg are very low in window period. In window period means between 6 months to 1 year. These antigens are quite low, but IgM anti-HBc are quite significant. The levels are quite significant. So this is an acute infection marker in window period. IgM anti-HBc, the orange one. Then comes total anti-HBc. Now IgM anti-HBc was formed first, but now this black one is total anti-HBc. It starts forming at around 4 weeks, keeps on forming in window period, and even in chronic, means recovery phase or chronic after even years, it stays, persists for life. Significantly, it mainly signifies past or current infection. The total anti-HBc signifies past or current infection and persists for life. Means infection has occurred at some point of time. Then comes anti-HBs. Anti-HBs is immunity, basically signifies immunity, maybe with infection or without infection. Past infection, either it has been cleared, thus anti-HBs immunity is there, or the lady has been vaccinated earlier, then also anti-HBs will be positive. Okay, so total anti-HBc and anti-HBs will stay positive throughout life, will persist throughout life. For vaccinated people alone, anti-HBs will be there. For past or current infection, and total anti-HBc will also be there, anti-HBs will also be there. And ALT, that is liver enzymes, mainly signifies clinical illness. Of course, in acute infection, it will be more, and it might be slightly higher in window period and might persist. But it will decrease, means it doesn't have a plateau type of curve. So the critical exam related points which are important for all of us to know are HBsAg positive for more than 6 months. HBsAg is this red one. Positive for more than 6 months means chronic infection. HBeAg positive plus high viral load means signifies high vertical transmission risk. Tenofovir needs to be given in 3rd trimester. Infectivity means viral vertical transmission risk is basically denoted through HBeAg and viral load. Anti-HBs only. Anti-HBs only means this green one. Means HBc is negative. This black one is negative, but only this green one is positive. That is anti-HBs. Means the lady is vaccinated. Not previously infected, but vaccinated. But if both are there, this green and black one, anti-HBs and anti-HBc both are there, then it means that past natural infection was there, which is resolved now. And this IgM anti-HBc, that is the orange one, denotes only acute or recent infection, less than 6 months old. In window period, HBsAg is gone, that is red one is gone, but anti-HBs is not yet up, that is immunity is not yet up. Only IgM anti-HBc will be positive mainly in the window period, this orange one. Okay, so if IgM anti-HBc is positive, then somewhere keep in your mind that window period is there, less than 6 months old infection is there. Okay, so hope this serology graph is clear to all of you. Again, to recapitulate, susceptible or never infected, none of these will be positive. In them, what will be your approach? Offer vaccination. If she is vaccinated, only anti-HBs will be positive. That means it is vaccine-induced immunity. Past infection means she is immune through past infection, not only through vaccination, through past infection. Then anti-HBc total anti-HBc and anti-HBs both will be positive. Means natural immunity resolved. Acute infection, in acute infection HBsAg will be positive. Total anti-HBc will also start rising. IgM anti-HBc will also be positive, and HBeAg will also be, might be positive or negative. But especially HBsAg will be positive. In acute infection, HBsAg, HBeAg might be or might not be, but IgM anti-HBc will also be positive. Then in window period, we saw that IgM anti-HBc is definitely positive and total anti-HBc is also positive, means early recovery. Just 6 months old infection is there, especially if only IgM anti-HBc is positive. Chronic diseases, high infectivity. Wherever infectivity is written, high infectivity means HBeAg will be positive. And in chronic infection, HBsAg and total anti-HBc will be positive. High vertical risk, and low infectivity means HBeAg is negative. But in all chronic infections, HBsAg will be also positive and total anti-HBc will also be positive. Occult hepatitis B is a rare condition in which total anti-HBc is positive. Their specialist follow-up is required. So pregnancy action trigger is what? HBsAg positive as soon as you find at booking. We carry out HBsAg. If it is positive, immediately order for viral load, HBV DNA, HBeAg to look for infectivity, and liver enzymes, means how the liver is doing. Tenofovir in third trimester is to be initiated, especially if viral load is more than 2 into 10 to the power 5. Then passive and active immunization is to be done. This is all regarding hepatitis B serology. Now let's come to another very important autoimmune condition, that is SLE. You might have noticed that its exam appearance is quite high and quite a lot of SBAs are being asked from SLE. Now let's have a look. What will you do pre-pregnancy? Disease, if it is stable, it has been stable without any remissions for 6 months or more, then we are quite happy. And we tell her to safely plan pregnancy. You can go for a check for antiphospholipid antibodies, anti-ROLA antibodies, complement levels, and ACR, that is albumin creatinine ratio. Kidney is actually affected, hence this. If she's having active disease, severe lupus nephritis, pulmonary hypertension, or recent stroke, then ask her to avoid pregnancy or at least postpone pregnancy for some time till these things stabilize. Regarding drugs, very important, if she is adequately stabilized on hydroxychloroquine, HCQ, then continue that. It is safe. Other drugs which can be safely continued are prednisolone, azathioprine, tacrolimus, and cyclosporin. What is to be avoided? These drugs are to be avoided. Methotrexate, mycophenolate, cyclophosphamide, all are teratogenic, and just remember roughly stop 3 months pre-pregnancy, okay, to avoid teratogenic risk. Antenatally, since again SLE is a condition which might predispose to development of preeclampsia, initiate aspirin, plus low dose, low molecular weight heparin, especially if antiphospholipid antibodies are there. If APS is overlapping, then along with aspirin, start thromboprophylaxis as well. Carry out growth scans every 4 weeks from 24 weeks onwards because of the risk of FGR. Then, in case of a flare in pregnancy, steroids are the mainstay. So either consider IV methylprednisolone, IVIG if very severe, or you can even increase the dose of prednisolone. If anti-ROLA antibodies are positive, which have happen in 2 to 3% cases. So anti-ROLA if positive, they pose a risk of congenital heart block. The chances are 2 to 3%. Okay, 2 to 3% is the percentage of risk of congenital heart block in anti-ROLA positive cases. In these patients, there may be a risk of congenital heart block. Hence, they are advised to undergo fetal echo once at around 16 to 18 weeks and then again at around 28 weeks. These are the time periods when it can develop and it can be detected. So ask the lady to undergo fetal echo at these gestational ages. Another risk is that of neonatal lupus. Now, neonatal lupus may present either in the form of skin rash, which usually resolves, or heart block. Heart block may be permanent and may need pacemaker. Delivery, there is no indication for cesarean section alone. Vaginal is usually preferred and aim at 39 to 40 weeks if everything is stable. Postnatal flares may occur. It is common at 6 to 8 weeks postpartum, hence monitor for it closely. Okay, so this is in brief regarding SLE. Now let's come to another autoimmune disease, that is IBD. Maybe in the form of Crohn's or ulcerative colitis. Our aim is to keep the disease in remission. Okay, pre-pregnancy, our aim is that she remains in remission at least 3 months or more prior to conception. Folate 5 mg is to be started if she is stabilized on sulfasalazine, if we have to continue sulfasalazine. Since it is folate antagonist, give her 5 mg folate throughout. Mesalazine, sulfasalazine, prednisolone, azathioprine, these biologics, anti-TNF, infliximab and adalimumab, they are safe drugs. Okay, so you can safely continue in pregnancy. However, again, methotrexate is to be avoided as it is teratogenic. Stop 3 months preconception. Thalidomide is also a teratogenic drug, which is to be strictly avoided. Regarding anti-TNF biologics, that is these infliximab and adalimumab, you can continue through the pregnancy, but consider stopping it later in the 3rd trimester if disease is stable. Okay, consider stopping it 32 weeks onwards. If there is a flare in pregnancy, optimize medical therapy. Corticosteroids, again, for any kind of flare, corticosteroids are the first line. So optimize medical therapy, corticosteroids are safe and biologics are also safe. If corticosteroids alone don't work, you can also give biologics. Mode of delivery is usually vaginal. CS, you can resort to cesarean section if vaginal delivery is somehow not possible because of active perineal lesions. If there is perineal lesion as in Crohn's disease and vaginal delivery seems not to be feasible, then you can resort to cesarean section. Or if ileoanal pouch anastomosis is there. This surgery is usually done for ulcerative colitis. If there is any ileoanal pouch anastomosis, then generally vaginal is possible but depends on case to case. If vaginal delivery is not feasible, then you can go for cesarean section. Then regarding postnatal, especially if the baby has been given these biologic drugs till late, then live vaccines are to be delayed up till 6 months. If she has been exposed to anti-TNF drugs in utero, then delay these biologic drugs, that is, delay these live vaccines up to 6 months. Breastfeeding, most of the IBD drugs are compatible. However, methotrexate is again to be avoided in breastfeeding ladies. Now let's have a quick look at antirheumatic drugs in pregnancy and lactation. which drugs to continue, which drugs to switch, which drugs to stop. Hydroxychloroquine, as we discussed, mostly in SLE it is given. You can continue, and even if you are giving for this rheumatoid arthritis, if she is stable on hydroxychloroquine, you can continue. It reduces flares and neonatal lupus, and it's even safe in breastfeeding. Sulfasalazine, again, it is pregnancy safe. However, add folate 5 mg. It's again breastfeeding safe. Prednisolone, try to keep it in lowest effective dose because it has got a small increase risk of cleft lip if given in first trimester and later on IUGR. However, in breastfeeding, again, it is safe. Azathioprine, it's safe. Continue if needed. In breastfeeding, again, it is safe. Cyclosporin and tacrolimus also, if it is being given in transplant patients, it's safe. You can continue in breastfeeding also. Biologic drugs, again, it's safe. However, stop towards the end of pregnancy, especially after 32 weeks if the disease is in remission. In breastfeeding, it's safe. Rituximab, avoid in pregnancy. It might lead to beta cell depletion. Rituximab use only if very essential. In breastfeeding, it's likely to be safe. Now, the drugs which you have to stop and avoid are methotrexate, mycophenolate mofetil, which is to be stopped especially 6 weeks preconception, cyclophosphamide, it's teratogenic also and gonadotoxic also, so avoid in both pregnancy also and in breastfeeding also. Leflunomide, again, cholestyramine washout may need to be given as it has got a long half-life. It is again to be strictly avoided both in pregnancy and breastfeeding. And NSAIDs. Now, NSAIDs, you can give from around 12 to 31 weeks, but after 30 weeks, avoid because it has got a chances of premature closure of ductus arteriosus. Hence, avoid, especially in the last 10 weeks of pregnancy. In breastfeeding, short-acting ones are fine to go ahead with. So, this is all regarding the anti-rheumatic drugs in pregnancy. So, hope it is clear till now, and let's proceed to the next topic. Transplant patients in pregnancy, renal, liver, heart, lung. If any solid organ transplant has taken place, then pre-pregnancy timing, wait 1 to 2 years post-transplant. Dr. Gayatri, please don't scribble, dear. Wait 1 to 2 years post-transplant and wait for the graft function to get stable. Creatinine, remember, 125. Try to keep the levels below this. In any renal transplant patient, aim for creatinine levels below 125 micromole per liter. If she is on mycophenolate mofetil, switch to azathioprine preconception. It is safer. If she is already on tacrolimus, cyclosporin, prednisolone, azathioprine, they all are safe. You can ask them to continue. Tacrolimus levels need to be monitored because the levels fluctuate quite much. So tacrolimus monitoring needs to be done. Levels often, on the whole, levels decline in pregnancy and sometimes dose might need to be increased. But unbound tacrolimus increases in pregnancy. Hence, it is very much required to check monthly tacrolimus levels. Okay, so remember, tacrolimus levels need to be checked monthly. Aspirin we need to give because transplant patients are at higher risk of preeclampsia. VTE prophylaxis also because transplant is a comorbidity. So consider antenatal and 6 weeks postnatal thromboprophylaxis. Growth surveillance, again 4 weekly scans from 24 weeks onwards. And mode of delivery, usually obstetric indication will decide. Kidney transplant in pelvis as such alone is not a cesarean section indication. But if required, it should be done with multidisciplinary input and transplant surgeon presence. Breastfeeding patients, tacrolimus, cyclosporin, and prednisolone are safe during breastfeeding. So this is in brief regarding transplant patients. So few things to lock in your mind. Never use methotrexate, mycophenolate, and cyclophosphamide during pregnancy and breastfeeding. Never stop hydroxychloroquine in SLE. It's not teratogenic. Never routinely prescribe ursodeoxycholic acid in mild ICP especially. No proven benefit. Never give estrogen contraception after ICP and especially if previous cholestasis is secondary to CHC use. Never miss the diagnosis of acute fatty liver of pregnancy. Apply Swansea criteria, especially if diagnostic features like hypoglycemia, vomiting and all are there. Don't miss AFLP diagnosis. And never delay biologic vaccinations in all IBD babies. Never delay biologic vaccinations means like don't presume that if she is IBD, she must have taken infliximab. So delay the BCG and all vaccination up to 6 weeks, up to later on. No. Only if she was was on anti-TNF drugs, then only delay. Otherwise, don't delay biologic vaccinations. Always continue hydroxychloroquine in SLE pregnancy if she has been stable on this. Prescribe aspirin in CKD patients, SLE patients, antiphospholipid antibody patients, and transplant patients. Plan birth by 35 to 36 weeks if she is severe ICP. Prescribe vitamin K if she is having prolonged PT or steatorrhea in ICP cases. Urgent deliveries to be planned for AFLP patients along with ICU care, and live vaccines should be delayed for 6 months if she has been given anti-TNF drugs in utero. So this was in brief. Again, to review, ICP, bile acid level drives the timing of birth. Ursodeoxycholic acid not routinely recommended in ICP, offer for pruritus only. AFLP, Swansea criteria. SLE, hydroxychloroquine continued. Anti-ROLA positive, CHB risk is 2 to 3%. Carry out fetal echo between 16 to 28 weeks. In IBD or in any other case, rheumatoid arthritis, if she's on methotrexate, stop 3 months preconception. Anti-TNF, you can continue safely. However, delay live vaccines for 6 months. In transplant patients, wait 1 to 2 years post-op and switch mycophenolate to azathioprine or safer drugs. Aspirin, LMWH, please don't forget. These are the top SBA pearls. Now, come on, let's have a look at the SBAs. A 32-year-old Gravida 2 para 1 at 34 weeks reports severe itching for 2 weeks. Bile acids are more than 100. ALT, no rash, BP, urine, ultrasound normal. What's the most appropriate timing of birth? Now we have in our mind that she is severe ICP, so we will search for option like this. So here it's very clear. Plan delivery at 35 to 36 weeks. At 38 weeks, no immediate CS, no start UTCA, no need, because here they are asking about timing of birth. Next, 28-year-old primey at 36 weeks presents with vomiting, abdominal pain, confusion. Now here we are slightly concerned about AFLP. ALT is quite high. Bilirubin again is quite high. Glucose less than 4, quite low. Platelets again low. INR, creatinine. Most likely diagnosis. Now here we look for Swansea criteria, whether she is fulfilling or not. Now bilirubin, ALT, glucose, vomiting, abdominal pain, confusion. These 6 criteria, they most probably lead us to AFLP. Help is again possible, but hypoglycemia, INR rise, and encephalopathy are more typical of AFLP. So AFLP is correct. Viral hepatitis may be possible, but this picture points more towards AFLP. ICP and hyperemesis gravidarum are very less likely. Some other scenarios, bile acids 45, that is mild, at not mild, moderate, at 36 weeks. When to deliver? So moderate, we will deliver, remember, between 38 to 39 weeks. Bile acids 110 at 33 weeks. Then when to deliver? Plan birth by 35 to 36 weeks, since it is more than 100. SLE on methotrexate wants to conceive, stop MTX 3 months before and switch to safer drugs. IBD patient on anti-TNF, baby born, vaccinate BCG, delay BCG life by 6 months. AFLP and 36 weeks pregnant, immediately plan delivery. ICU admission, correct hypoglycemia and coagulopathy. Renal transplant on mycophenolate mofetil, 6 weeks pregnant. Stop MMF immediately and switch to azathioprine. Anti-Ro positive SLE at 18 weeks, the risk of congenital heart block. So carry out fetal echo. Risk is approximately 2 to 3%. So you will carry out fetal echo at 16 to 18 weeks and then again at 28 weeks. NSAIDs plus 32 weeks pregnant. Should it be given? No. Try to avoid because of the risk of premature closure of ductus arteriosus. So again, these are the summary anchors, the same things. For AKI, do a KDIGO staging, avoid nephrotoxins. In ICP, UDCA not routine. AFLP, Swansea criteria, remember. Hypoglycemia is the key. SLE, continue hydroxychloroquine. These already we dealt with multiple times. And any transplant, very important to wait for at least 1 to 2 years. Mycophenolate mofetil is a strict no during pregnancy. Switch to azathioprine. Tacrolimus level monitoring is very, very essential because unbound tacrolimus levels are high in pregnancy. So levels need to be monitored. If hepatitis B virus, viral load is high, try to give tenofovir in 3rd trimester. If it is co-accompanied with HIV in co-infection, then tenofovir-based CART is given. HIV viral load if more than 50, plan cesarean section. Formula feeding is advisable in breastfeeding women. Now let's come to our next segment, that is neurological and mental health. Very, very important condition here is epilepsy. So for epilepsy, its exam appearance, around 70%. Means many questions are being asked from epilepsy. Drug, we need to know about the drugs very well. If a lady comes to you with epilepsy, planning for pregnancy, first you will ask about her seizure control. Aim seizure-free for 1 year before conception at least. Your aim should be this. Counsel her that it would be very good if you were seizure-free for 1 year before conception. Then go on to review her drugs. If she is on valproate, try to switch it to better drugs, that is safer drugs, that is lamotrigine or levetiracetam preconception in coordination with her neurologist. Okay? Folic acid has to be given 5 mg from 3 months before conception up till 12 weeks. Not throughout, up till 12 weeks. Prefer AED, anti-epileptic drug monotherapy. Polytherapy doubles the teratogenic risk, around 16%. So polytherapy, instead of polytherapy, try that she should be controlled on AED, anti-epileptic drug monotherapy. Avoid sodium valproate. 10% major malformation risk is there. Also, neurocognitive behavior impairment, decreased IQ. Hence, sodium valproate is preferably avoided. In fact, valproate is avoided in young women. Those who might get pregnant, try to avoid prescribed valproate. They say that in young women, try to avoid prescribing valproate if there are any chances that she might get pregnant. Only if there is no alternative, then only they prescribe valproate. This is according to PREVENT program. The preferred anti-epileptic drugs are lamotrigine and levetiracetam. They have got the lowest teratogenicity. Then again, just like we were monitoring tacrolimus levels in pregnancy, lamotrigine levels also need to be monitored in pregnancy because clearance rate is high and there are very high chances of lamotrigine fluctuation in pregnancy. Hence, it is required to monitor lamotrigine levels. Vitamin K, 10 mg per oral daily last month if she is on enzyme-inducing anti-epileptics like carbamazepine, phenytoin, all the Zepin drugs, phenytoin, primidone, all these drugs are enzyme inducers. So if she is on enzyme inducer, then prescribe her 10 mg vitamin K per oral daily in the last month. The safety matrix, major malformation risk, the preferred ones are lamotrigine and levetiracetam. They have got around 3% or 2% major congenital malformation risk only. So try to switch valproate to these preconceptional drugs. If she is seizure-free for 2 or more years, then we might consider stopping the drugs preconception. But all this needs to be done with multidisciplinary input, especially with neurologist input. Then comes the drugs which can be given with caution, have got moderate risk. Carbamazepine 5%, phenytoin 6%. These are MCM rates, that is major congenital malformation rates. Phenobarbital, topiramate is associated with cleft lip and cardiac defects. And one more thing which we dealt with in the last slide, enzyme inducers need vitamin K 10 mg per day in the last month. And also add folate 5 mg up till 12 weeks. This is a must with any anti-epileptic. Then comes the big avoid drug, that is sodium valproate. It has got very high major congenital malformation rate along with low IQ. So just know this program. There is a prevent pregnancy program by drug authorities of UK, that is MHRA, Maternal Health Regulatory Agency. They are running prevent pregnancy program. It is especially in relation to teratogenic drugs like these, where it is strictly told to avoid pregnancy. So if they are on sodium valproate, they strictly are advised to use contraception, very reliable contraception. They need to undergo annual review, and they also advise neurologists to prescribe these to young women only if no alternative and with full information. So ideally sodium valproate is to be avoided to any woman planning pregnancy or if already pregnant. Now let's come to headaches. Migraine is very frequently asked. Most of the migraine cases, they improve in pregnancy. However, postpartum flare is common. If they ask you, which is the first line drug in pregnancy for migraine, it's paracetamol. It is safe in breastfeeding also and pregnancy also. NSAIDs are usually required if paracetamol doesn't work, but prefer to give only in first and second trimester and avoid after 30 weeks. In breastfeeding, short-acting drugs like ibuprofen are okay to prescribe. Now, regarding triptans, most data say that sumatriptan is safe, but don't consider it as first line. Prescribe only if severe or not responding to NSAIDs. Breastfeeding, sumatriptan is compatible. However, wait 12 hours to feed. Antiemetics are all safe in pregnancy. Topiramate is to be avoided as it poses a risk of cleft lip. Propranolol prophylaxis is safe. For prophylaxis of migraine, commonly used drug is propranolol. So it's safe in pregnancy and breastfeeding. However, amitriptyline prophylaxis is to be used with caution. However, there is no firm evidence of harm, but it is to be used with caution in pregnancy and breastfeeding. Strict no's are ergotamine and long-term opioids. They are not safe in pregnancy and hence are to be avoided. Now, wherever there is new severe headache in pregnancy, think in your mind or keep in your mind regarding the diagnosis of preeclampsia, eclampsia, cerebral vein thrombosis, PRES, especially if she was preeclamptic earlier, stroke or transient ischemic attack, intracerebral hemorrhage, or meningitis, depending on the complete scenario. Do think about these if there is new onset severe headache in pregnancy. Now next coming to perinatal mental health. So mental health is in fact a leading cause of late maternal death. As we saw, suicide is the leading cause of late maternal death. Antenatal depression, the prevalence is 10 to 15%. Also postnatal depression, again 10 to 15%. Recurrence is variable for antenatal depression, but for postnatal depression, especially the recurrence in next pregnancy is very high. As far as postpartum psychosis is considered, prevalence is not as common as depression, but it is more severe condition, 1 to 2 per thousand. The prevalence is 1 to 2 per thousand. Recurrence in next pregnancy is 30%, and it increases to 50% if bipolar disorder is also there. Bipolar disorder relapse prevalence is 50% antenatal and 70% postnatal. Recurrence in next pregnancy is quite high. Disorders, mental disorders like OCD, anxiety, PTSD are all very common and often missed. So we should be on the lookout for these conditions strictly in the scenario questions. Now, what are the questions which relate to depression? Two kinds of questions are there. For initial screening, woolly questions are these two. During the past month, have you often been bothered by feeling down, depressed, or hopeless? Second question, have you often been bothered by little interest or pleasure in doing things? If they are giving you these two questions and are asking what are these questions and for what they are used, they are woolly questions and they are used for depression screening. Along with this, also ask, is this something you feel you need or want help with? So these are the woolly questions. Also, the another scale which is commonly used for depression is Edinburgh Postnatal Depression Scale. Score if comes out to be more than 10, then she is to be evaluated further for depression. So remember, woolly questions and Edinburgh Postnatal Depression Scale are for screening depression. Next come psychotropic drugs. Again, in maternal medicine, the drugs are very important. So we need to know what drugs are safe, what drugs to be avoided. Risk versus benefit and relapse. And it is very important with psychotropic drugs that they are never to be stopped suddenly. Okay. So wherever the question says that you have to stop suddenly, so stop this. Also don't prefer to choose that option. So let's have a look at the drugs one by one. Sertraline, remember, is the first line SSRI in pregnancy and breastfeeding. Also in breastfeeding, it's first line. So sertraline is the preferable, most preferred drugs. Citalopram and escitalopram is also generally safe and breastfeeding compatible, but safest is sertraline. Fluoxetine use is also okay, but one caution, it has got long half-life. Fluoxetine has got long half-life, hence review. And in breastfeeding also it is to be used with caution as it has got a long half-life. Then coming to paroxetine, avoid in first trimester as it has got cardiac defect risk. Although it is breastfeeding compatible, but due to cardiac defect risk, avoid in first trimester paroxetine. SNRIs like venlafaxine use only if benefit outweighs risk. Otherwise, try not to use, although it is compatible in breastfeeding. Again, tricyclic antidepressants use only if SSRIs have failed. However, it is breastfeeding compatible. Then another very important drug commonly asked in SBAs and EMQs is lithium. Epstein's anomaly, remember, it is associated with lithium use. You have to counsel regarding that and consider switching this drug to a safer drug. Avoid in breastfeeding. Again, lithium is toxic in breastfeeding. Sodium valproate, strict no. Safe in breastfeeding if levels are okay. It is not very much transferred to infant. Okay, so sodium valproate as such is safe in breastfeeding if levels are fine. Lamotrigine mood stabilizer. It is a preferred mood stabilizer in pregnancy. In breastfeeding, it is safe. However, it is transferred to fetus more than that of sodium valproate, but it is safe. Antipsychotics, olanzapine and quetiapine continue if beneficial. These are generally safe. And regarding benzodiazepines, use for short term only. In third trimester, if you use, it might lead to floppy infant syndrome. Also, it has got interaction with olanzapine. So often it is said that lorazepam and olanzapine don't use together. In breastfeeding, lorazepam short acting is okay to use. So these are the main psychotropic drugs which you should know about. If any time you are asked to choose the drug of choice for depression, then it is always sertraline. Regarding lithium, some few important points because separately it is very much asked. Relapse rate is 50% if you stop lithium abruptly. Hence, it is never to be stopped abruptly. Okay. The risk is that of Epstein's anomaly, where tricuspid valve is down displaced. Although the absolute risk is low, but still it is there, 1 in 1,000. If stopped, 50% relapse risk is there. And there are high consequences. Even suicide and infanticide might be there. Preconception counseling is very much required. MDT input is very much required. If it is to be continued, try to use it in lowest effective dose. Check the levels monthly and then in each trimester specifically and more frequently later on. Anomaly screening is very much advisable. Fetal echo you need to do at 18 to 20 weeks. Specifically, if they ask with lithium, fetal echo is must to rule out abstains. Lithium levels, toxicity risk is more in dehydration if you give NSAIDs, vomiting, and hence you have to avoid any trigger which aggravates hyperemesis because then toxicity risk will be more. During labor, check the levels of lithium and electrolytes because there is risk of toxicity from fluid shifts. Hence, level checking is important. Then postpartum, as soon as the lady delivers, try to reduce the dose to pre-pregnancy levels in coordination with MDT input. Check levels 12 hours after birth. Avoid lithium in breastfeeding, strictly avoid because it concentrates in milk. In neonate, floppy infant syndrome is possible. Hence, if she has been on lithium and she has been breastfeeding, pediatric review is a must. So these are a few important points regarding lithium. Now let's come to postpartum psychosis. Again, this is very commonly asked. MBR race, top late cause of death is suicide, which usually results from postpartum psychosis or depression. Incidence is 1 to 2 per 1,000 births. Time of onset is typically in first 2 weeks postpartum. See, the time of onset of depression is later on, 2 to 4 weeks postpartum and still later, even 2 to 4 months. But postpartum psychosis, the onset typically occurs within the first 2 weeks. Can be as early as day 2, 3, 4 or 5. How the lady presents: confused, with delusions, hallucinations, mania, severe depression, and suicidal or infanticidal thoughts. Risk factor, the biggest risk factor is previously she also had suffered with postpartum psychosis. So previous postpartum psychosis, the recurrence is 50%. Again, bipolar disorder may also predispose and a family history may also predispose. Regarding pre-pregnancy planning, if suppose she has already had postpartum psychosis in previous pregnancy, MDT planning is must. Some women restart prophylactic lithium late in third trimester or postpartum. So hence pre-pregnancy planning is very much advised. If suppose you suspect postpartum psychosis, immediately you need to involve perinatal mental health specialists, PNMH, and urgent psychiatric admission to mother and baby unit is required. MBU is the mother baby unit where you need to urgently admit the mother and baby. Treatment usually through antipsychotics, lithium, or electroconvulsive therapy if the condition is severe. And be on strict lookout for suicidal ideation. What message MBR race gives? That mental illness is a top late maternal death cause, and ask about mental health at every visit. It's very, very important. Future pregnancy, always plan with perinatal psychiatry inputs and consider prophylactic medications if advisable. So postpartum psychosis, you need to be well aware the time of onset, okay? And things like MBU, PNMH involvement, these things. Next, another important thing is topic is substance misuse in pregnancy, opioid, smoking, alcohol dependence. So without any judgmental approach, the lady needs to be dealt with. We have to emphasize on harm reduction to the fetus. And MDT input again is very important here. First, let's deal with alcohol. Pregnancy effect, fetal alcohol spectrum disorder, miscarriage, FGR, stillbirth may be there. Advise abstinence. SIVA scoring is there. And thiamine. This is Clinical Institute withdrawal abstinence. So SIVA scoring is specifically for alcohol. And thiamine is also advised. Then tobacco, regarding tobacco, the risks may be FGR, abruption, preterm birth, SIDS. Here, if she is tobacco dependent, then nicotine replacement therapy is advisable. This is okay. But Some stop smoking drugs are there, like varenicline or bupropion. These kind of drugs are to be avoided. So if they ask you that she was on tobacco, would you prescribe varenicline in pregnancy? No. Nicotine replacement therapy is advisable, but varenicline and drugs like bupropion is avoided. What about opioid misuse? If she is on opioids, there may be symptoms of withdrawal in mother and even in neonate abstinence syndrome. So, methadone or buprenorphine substitution is advisable. Do not abruptly stop the opioids in pregnancy. Do not detox in pregnancy. But it is highly advisable to put them on methadone or buprenorphine substitution. Cocaine might lead to vasoconstriction, hence disastrous consequences like MI, stroke, abruption, or FGR. So it needs to be stopped and cardiac assessment needs to be done. Regarding cannabis, it also has got mild FGR, long-term cognitive effects, counsel regarding cessation. Benzodiazepine in first trimester leads to cleft lip, floppy infant in third trimester, taper slowly. Do not stop abruptly. Regarding neonatal abstinence syndrome, NAS, onset is usually 24 to 72 hours after birth if the lady was on opioids and she has given birth. You will start seeing the symptoms of NAS within 24 to 72 hours. There is a scoring, know this name, Finnegan scoring. This is especially used for neonatal abstinence syndrome, and morphine titration is done in NICU. Means babies are kept in NICU for few hours or few days, and neonatal abstinence syndrome is dealt with morphine titration. So again, some locking points. Never use sodium valproate in women of childbearing age according to PREVENT program. Never stop anti-epileptics abruptly in pregnancy. Never breastfeed on lithium. Never detox heroin completely during pregnancy. Instead, use methadone or buprenorphine substitution. Never miss postpartum psychosis red flags in the lady. Never use topiramate. It might lead to cleft lip. Always switch valproate to safer drugs preconception. Always give folate 5 mg in epilepsy and especially 3 months preconception and up to 12 weeks postpartum. Always prescribe vitamin K 10 mg per day if she is on enzyme-inducing anti-epileptics. Always use methadone or buprenorphine substitution instead of stopping opioids abruptly. Use Bully questions plus EPDS at every contact to screen for postpartum depression or antenatal depression. Sertraline is the preferred SSRI in pregnancy as well as breastfeeding. Okay, so these are the key points. Now let's come to the questions. A 26-year-old primey with focal epilepsy on sodium valproate 1 gram BD presents at 8 weeks pregnant, although already she is pregnant. She has been seizure-free for 2 years. What is the most appropriate management? Continue valproate? Not very much. Stop valproate immediately? Again, not a good option. MDT review plus gradual switch to lamotrigine and folate 5 mg seems to be a good and correct option. Switch to phenytoin, again not very safe. Continue valproate but add lamotrigine. Try to keep her on monotherapy, not polytherapy. So the best option here seems to be C, MDT review. Similarly, other scenarios, if she's day 8 postpartum, presenting with agitation, delusions, and suicidal thoughts, most probable diagnosis is postpartum psychosis as she is in first 2 weeks of pregnancy. Emergency psychiatric admission means involvement of PNMH specialists and admission in MBU is advisable. If she is 8 weeks pregnant on lithium, again MDT needs to be involved. First trimester, so counsel regarding Epstein's anomaly risk and carry out fetal echo at 18 to 20 weeks. So choose option which contains any of these. Heroin user, 24 weeks pregnant. Will you withdraw immediately? No. Instead, use methadone or buprenorphine substitution. Do not detox. EPDS, that is Edinburgh Postnatal Depression Scale, more than 10 is bad. So she's 14 at 6-week check. However, there is no suicidal ideation. what will you do? Since score is high, we will immediately involve the perinatal mental health team and consider her for drug therapy, preferably sertraline. Epileptic on carbamazepine. What about vitamin K? Yes. Since it's an enzyme inducer, vitamin K 10 mg per oral daily in last month of pregnancy we can give. Migraine at 32 weeks. Paracetamol fails. What next? Since NSAIDs are not very safe after 30-31 weeks, hence we can consider sumatriptan. New onset seizure in third trimester. Guys, again, very, very important. Any new onset seizure in third trimester, consider it eclampsia until proven otherwise. And start the eclampsia drill, eclampsia management. Magnesium, BP monitoring, urine delivery, planned delivery. So, summary anchors, valproate, strict no, lamotrigine, levetiracetam preferred, folate to be given, vitamin K if enzyme inducers, monotherapy, prefer instead of polytherapy, and keep in mind this prevent program for me, right? Says to avoid valproate in reproductive age ladies. Regarding mental health, sertraline first line SSRI, lithium has abstinence risk, not in breastfeeding, postpartum psychosis incidence is 1 to 2 in 1000. Recurrence is 50% if previous. MBU admission preferred. Go for Woolley and EPDS screening for postpartum depression. In migraines and substance abuse, paracetamol is first line drug in migraine. Avoid NSAIDs beyond 30-31 weeks if she's on heroin. Go for methadone or buprenorphine substitution instead of stopping abruptly. Don't detox. Tobacco NRT is okay, but not that varenicline and all. Topiramate avoid due to risk of cleft lip. Again, the same things. Folate, vitamin K, sertraline, lithium, and postpartum psychosis is a psychiatric emergency. Recurrence 50%. Okay. Hope it's clear up till now. Now let's have some last topics. Look at the last topics, that is acute emergency. So now sepsis is a very, very important topic and it has got latest GTG also. So please go through that. Few important terms are Q-SOFA score. Q-SOFA score, 2 or more means high risk. Okay. Surviving sepsis exam appearance is very high. This 2 or more score means high risk. And what are the components? How will you derive Q-SOFA score? If respiratory rate is 22 or more, she's in altered mental state with GCS less than 15, and systolic BP is less than equal to 100, means 100 or less. Any two of these, if 2 or more are there, then that means she's at high risk. Then comes what are the components of sepsis 6. Within 1 hour, what you will do? Give high flow oxygen. Target should be more than 94%. Take blood cultures and other cultures depending on the focus of infection. Give IV broad spectrum antibiotics and IV fluids at the rate of 30 ml per kg crystalloid. Measure serum lactate. More than 2 is significant and 4 or more is severe. Measure urine output through catheter hourly. So these are the 6 components of sepsis 6 bundle to be done within first hour. Plus, recognize maternal physiology, consider the source, what is the focus of infection, and give empirical antibiotics according to local protocol. Remember what is given in GTG. Commonly, piperacillin, tazobactam, or coamoxiclav plus gentamicin are the preferred ones. So, hospital unit protocol is to be strictly followed while giving broad spectrum empirical antibiotics. Then comes hyperemesis gravidarum. As such, nausea vomiting of pregnancy, it is covered there, but just a few important points as sometimes it can become an emergency. Puke 24 score is used. Earlier, they used to give a triad to diagnose hyperemesis gravidarum of weight loss, electrolyte imbalance, and dehydration. But now in the new guideline, they have said that any nausea vomiting of pregnancy, which is limiting the oral intake, that the lady is unable to take anything by mouth and is strongly limiting the daily activities, that is termed as hyperemesis gravidarum. In Puke 24 score, just know this, 6 or less is mild, 7 to 12 is moderate, 13 or more is severe. Investigations to be carried out are these: urea electrolytes, LFT, FBC, glucose, midstream urine, and ultrasound scan to rule out multiple or molar pregnancy. First line antiemetics are the antihistamines. Second line are the metoclopramide and ondansetron and domperidone, MOD. Metoclopramide, remember, not give for 5 days or more, not give for more than 5 days because of extrapyramidal risk. Ondansetron has got higher risk of constipation and slightly increased risk of cleft palate. Third line, corticosteroids. Last resort, hydrocortisone IV. When stable, prednisolone per oral, you can switch. IV fluids, normal saline along with KCl as needed. Avoid giving dextrose alone. It might precipitate wernicase encephalopathy. So, thiamine is essential to avoid wernicase. IV, it can be given as IV Pabrinex or per oral thiamine 50 mg TDS, especially before initiating glucose. LMWH thromboprophylaxis is very much required, especially if she is admitted for hyperemesis gravidarum. Cover with LMWH. Admission criteria, wherever community care and ambulatory daycare is not sufficient, she is unable to tolerate oral fluids or medicines, weight loss is occurring, any comorbidity or complications like UTI, HIV, mental health complications are there, clinical dehydration symptoms means clinical dehydration symptom signs are visible, and she is unresponsive to oral management. That is, not responding to community or ambulatory daycare. These are the red flags and the indication for inpatient admission. So hope hyperemesis is clear. Next, come to diabetic ketoacidosis, another emergency which can arise in pregnancy. It is important to know that it can occur at lower glucose levels also. So euglycemic DKA may also be there. Here there is a triad of hyperglycemia or euglycemia along with ketonemia and acidosis. Ketonemia and acidosis. So the name itself says. Triggers may be any dehydrating thing, infection, vomiting, missed insulin, steroids, beta sympathomimetics might also trigger. Diagnostic criteria, capillary ketones of 3 or more or ketonuria 2+. Then pH, keto, so capillary ketones 3 or more or ketonuria 2+. Acidosis means pH less than 7.3 or bicarbonate less than 15. What is the first line action you will do? Immediately, fluid replacement. Start with fluid replacement, 0.9% saline 1 liter in first hour. Then titrate it. Aggressive initial resuscitation is required along with insulin infusion at fixed rate of 0.1 unit per kg per hour and titrate according to glucose levels. Now, the target levels of glucose are to be kept between 10 to 14. Don't try to bring it too low to prevent hypoglycemia. Hence, fluid insulin, but insulin is to be strictly titrated according to glucose levels. Add 10% dextrose when glucose levels fall below 14 and keep on continuing insulin for ketones. Potassium you can add if potassium levels are low and strictly monitor fetus because fetus might be at risk. Continuous CTG monitoring is to be done, especially it is advisable. If CTG is suspicious or pathological, wait, because sometimes when this gets corrected, it resolves. So CTG might be non-reassuring, but it resolves with maternal correction. Again, it is mentioned in MBR race that it is a very preventable cause of maternal and perinatal death if recognized timely. Then now let's come to anaphylaxis in pregnancy. You all must be familiar with mast cell tryptase questions in your recalls. So remember, Resuscitation Council UK says that it is to be managed in same way as non-pregnant. How it can manifest? Sudden onset, airway, breathing or circulation compromise, along with skin or mucosal changes. First, put her in left lateral tilt position to relieve aortocaval compression, and the drug of choice is, as you all know, adrenaline. Intramuscular 500 mcg. Repeat every 5 minutes if no response. This you have to remember. 0.5 mg IM to be repeated every 5 minutes. High flow oxygen 15 liters via non-rebreather mask because breathing compromises there, along with IV fluids, crystalloids, 500 to 1000 ml bolus, and then switch to antihistamines, corticosteroids because it's anaphylaxis. So we will give anti-allergics. So give in the form of antihistamines and corticosteroids. Although slightly controversial role of hydrocortisone, but yes, you can give. In refractory cases of anaphylaxis, ICU admission is required and adrenaline infusion might need to be started. Do continuous CTG. If it is very severe and has led to maternal collapse, the maternal collapse guidelines will imply. You will do perimortem cesarean section if in case required and maternal arrest has happened for more than 4 minutes have passed, try to do perimortem cesarean section. Mast cell tryptase levels can be used, take 1 hour and 6 hours after event. Peak comes at 1 to 2 hours. So this is mostly sufficient with regards to anaphylaxis in pregnancy. Never forget the maternal collapse table, 4 H's, the reversible causes: hypoxia, hypovolemia, hypoglycemia, hyperkalemia, electrolytes, hypocalcemia, that is electrolyte thing, and hypothermia. So oxygen, volume, electrolyte, and temperature. 4 T's comprise thrombosis, the topmost leading direct cause, toxins, tension pneumothorax, and tamponade cardia. So these are 4 T's. Other pregnancy-specific causes include eclampsia, amniotic fluid embolism, aortic dissection, pulmonary edema, and intracranial hemorrhage. In aortocaval compression, apply left lateral tilt for all CPR. Wherever you initiate CPR, the position should be adequate after 20 weeks. And resort to perimortem cesarean section within 4 minutes and carry out by 5 minutes of arrest if there is no return of spontaneous circulation to improve both maternal as well as fetal outcome. Mainly done to improve the effectiveness of CPR. Just have a quick look at drugs in maternal collapse. Now, drugs are cause specific. You need to know the outlines. Like for cardiac arrest or profound hypotension, the drug of choice is adrenaline or epinephrine IV. 1 mg, 1 in 10,000. This is in fact first line vasopressor in advanced life support. If you consider supraventricular tachycardia with narrow QRS complex, the drug of choice remains adenosine. 6 mg can be increased up to 12 mg IV bolus. This stays the first line for acute supraventricular tachycardia, adenosine, and is safe in pregnancy. Cardiogenic shock, wherever there is low cardiac output, BP more than 90, for example, in PPCM, you encounter cardiogenic shock. There, dobutamine IV infusion is preferred over dopamine. In PPCM, you will also notice that one drug called levosimendan is given. But for now, just go with dobutamine IV infusion as the preferred drug, beta-1 inotrop. If both are given, dobutamine and dopamine, prefer dobutamine. Septic shock with persistent hypotension, give noradrenaline IV infusion. It's first line vasopressor in sepsis. Surviving sepsis campaign, noradrenaline IV infusion is the first line. Whereas in ALS, it's adrenaline. In pulmonary embolism, we all know we will give thromboprophylaxis, unfractionated heparin IV. Thromboprophylaxis, no treatment, means unfractionated heparin IV is reversible and safe, and once stable, you can switch to LMWH. Massive pulmonary embolism with hemodynamic collapse, aggressive treatment is required in the form of thrombolysis, alteplase, used when, especially when PE causes shock or arrest, means urgent aggressive treatment is required, then we do thrombolysis. Eclampsia with seizures, we all know, Maxulf, 4 gram IV loading dose, followed by 1 gram per hour infusion. Deliver the baby immediately, gold standard for seizure control. So if you want to remember it, it's adrenaline, adenosine, dobutamine, noradrenaline, unfractionated heparin, thrombolysis, Maxelf. Okay. Refractory VT, as such for supraventricular tachycardia, you are giving adenosine. But for refractory ventricular tachycardia, amiodarone can be given. For pulmonary edema, just specifically for the duration till which edema is relieved, give furosemide. Next, very important cause, although it is rare but devastating with very high mortality, is amniotic fluid embolism. Often it's a clinical diagnosis of exclusion because it can only be confirmed on post-mortem. So incidence is rare, 1 in 8,000 to 1 in 80,000. However, it has got a very high case fatality rate of 20 to 60%. Triad is often found of hypoxia, hypotension, and coagulopathy. DIC will often accompany. DIC features are there. Plus minus seizures, but often hypoxia, hypotension, and DIC. Timing usually in later part of pregnancy or immediately postpartum. During labor, immediately postpartum, or after cesarean section. Often we see sudden collapse. The risk factors are advanced maternal age, induction of labor, instrumental deliveries, cesarean section, polyhydramnios, multiple pregnancy, abruption. All these might predispose a little more towards amniotic fluid embolism. Diagnosis, as we discussed, is clinical. No diagnostic test is in fact there. Post-mortem reports might show fetal squamous in the lungs of the lady. Initial management, CPR, airway, means life support basically we have to give. IV access, correct hypovolemia. For coagulopathy, which is often found, resort to massive transfusion protocol. RBC, FFP platelets transfuse in the ratio of 1:1:1. Cryoprecipitate may also need to be given along with tranexamic acid. Again, here perimortem cesarean section will come into play. Within 4 to 5 minutes if maternal arrest has happened beyond 20 weeks. It requires urgent ICU admission, vasopressors, ECMO if available, along with intensive care, and report to UK Obstetric Surveillance System, National Registry. So these are the main management components of amniotic fluid embolism. Regarding PPH, as such, PPH will be covered in postpartum or labor and delivery. But since it's an emergency condition again, so you need to know roughly regarding 4 T's as the causes of PPH. Tone trauma tissue thrombin. The drug ladder, that is pharmacological management of atonic PPH. We all know it's oxytocin, 10 units IV slow plus infusion. Ergometrine, 0.5 mg IM, however avoid in hypertension and asthma. Carboprost, 250 microgram IM, every 15 minutes up to 8 doses, however avoid in asthma. Misoprostol, 800 microgram per rectal or sublingual. Tranexamic acid, 1 gram IV. All these are pharmacological agents used in PPH. Regarding if the patient is not responding, we have to resort to mechanical or surgical measures through bimanual compression, balloon tamponade, Bielen's suture, uterine artery ligation, embolization, interventional radiology involvement, and hysterectomy. So again, some lock points. Never give dextrose alone in hyperemesis gravidarum without thiamine. It might precipitate wernicase. Never delay antibiotics in maternal sepsis. Never stop CPR before perimortem cesarean section in cardiac arrest more than 20 weeks. Means while you are performing perimortem CS, continue doing CPR, means resume CPR immediately after, and till the time you have initiated perimortem CS, keep on giving CPR. Use ergometrine, never use ergometrine in hypertension and asthma. Never forget left lateral tilt in CPR after 20 weeks, and never use carboprost in severe asthma. Always give thiamine before glucose in malnourished or hyperemesis gravidarum patients. Always use sepsis 6 within 1 hour of admission. Always resort to perimortem cesarean section within 4 to 5 minutes if there is no return of spontaneous circulation. Always use oxytocin as first line for PPH. Always use crystalloids 30 ml per kg in septic shock. and tranexamic acid 1 gram IV in PPH. So these are the top SBA pearls. Sepsis 6, Q-SOFA score. Always, again remember, Q-SOFA score comprises these three. Respiratory rate more than 22, GCS less than 15, systolic BP less than 100. Proves that sepsis is severe until proven otherwise. Hyperemesis, thiamine before glucose. DKA might be euglycemic. Check ketones, not just glucose. Maternal collapse, 4H40. Perimortem cesarean section within 4 to 5 minutes at more than 20 weeks. Amniotic fluid embolism, the triad is that of hypoxia, hypotension, and DIC. Massive transfusion protocol is to be followed and report to UK obstetric surveillance system. Now let's come to SBA again. A 32-year-old gravida 2 para 1 at 30 weeks attends with fever 39 degree, abdominal pain and vomiting. Respiratory rate is high, heart rate is high, BP is less than 100 systolic, GCS less than 15. White cell count is high and lactate is also going towards 4, more than 2. What is the immediate priority? So here we completely see that Q-SOFA score is more than 2 and she is sepsis. So our priority will be to initiate sepsis 6 bundle within 1 hour. Okay. No need for first doing imaging or oral co-amoxiclav. No need paracetamol and repeat obs in 1 hour, continuous CTG only. All these are not feasible options. The best is Q-SOFA 3 since it is more than 2. So sepsis 6 bundle within 1 hour. Next, a 36-year-old gravida 3 para 2 at 32 weeks collapses during induction. No pulse, no breathing, CPR initiated. After 4 minutes, still no return of spontaneous circulation. In 4 minutes, no return of spontaneous circulation. Next priority will be perimortem cesarean section within 5 minutes, right? IV adrenaline and all can be continued, but the main priority here, if they are giving the time duration, they are giving more than 20 weeks. So first priority here is PMCS. Some other recall scenarios, hyperemesis with plus vernicase after IV dextrose. So here we will start thinking about thiamine. Pregnant plus sudden hypotension plus DIC during labor. Here we should keep in mind it is going towards hypoxia, hypotension, DIC during labor, going towards suspect amniotic fluid embolism, massive transfusion and ICU admission. Cardiac arrest at 28 weeks. At 4 minutes, still no return of spontaneous circulation. Think about perimortem CS. DKA, glucose 9 millimole per liter. It's less. But still, yes, euglycemic DKA is possible in pregnancy. So check for ketones. PPH plus asthma, drug of choice is oxytocin and misoprostol. We have to avoid carboprost. Sepsis at 30 weeks with fever and uterine tenderness. Think about chorioamnionitis. Wherever uterine tenderness and on top of that, if leaking is also there, prom is also there, P-prom, then chorioamnionitis is the topmost diagnosis. Give antibiotics and plan delivery. Maternal collapse plus epidural was just given. If suppose it is happening in relation to regional analgesia, then think about total spinal high block, airway support and adrenaline support might be required. So again, the summary anchors: sepsis plus DK, sepsis 6 within 1 hour, Q-SOFA, lactate, euglycemic, this all we have gone through. Puke 24 is essential for hyperemesis gravidarum, thiamine before glucose, cyclizine first antiemetic, LMWH while admitted, collapse, perimortem CS at 5 minutes, within 5 minutes. Anaphylaxis, the drug of choice is adrenaline 0.5 mg/IM, repeated every 5 minutes, left lateral tilt, amniotic fluid embolism, and all this we have gone through. Doses to memorize, emergency drug reference card. Just go through quickly. Adrenaline, the dose is 0.5 mg/IM, 1 in 1000, repeat every 5 minutes. For anaphylaxis. For cardiac arrest, it's IV. 1 mg/IV, 1 in 10,000, repeat every 3 to 5 minutes. Remember this, very important. Maxil floating dose, we all know, 4 gram IV over 5 to 10 minutes, and this is loading. And maintenance, we continue infusion of 1 gram per hour for 24 hours after birth or last seizure. Calcium gluconate in case of Maxil toxicity, we give 10, 10, 10. 10 ml of 10% IV over 10 minutes. Oxytocin for PPH, either 10 units IV slow or 40 units infusion for atonic PPH. Ergometrine 0.5 mg IM. Carbopros 0.25 mg IM every 15 minutes for maximum of 8 doses. Misoprostol 800 microgram per rectal or sublingual for uterine atony. Tranexamic acid 1 gram IV given over 10 minutes. Repeat once. Hydrocortisone 200 mg IV, anaphylaxis or steroid dependent, and chlorpheniramine also can be given in anaphylaxis. Now last few slides related to special situations and social factors. One very important, breast cancer in pregnancy, new GTG is there. Don't delay investigation. Pregnancy is not a reason to skip workup of breast cancer. So for any lump in pregnancy, carry out an ultrasound first. Mammogram is also safe with abdominal sheet. Carry out core biopsy under local anesthesia. MRI is also safe without gadolinium. Avoid gadolinium if possible. When we look at the treatment modalities of breast cancer, we need to know that surgery is in fact safe in any trimester, but reconstruction needs to be delayed to postpartum. Sentinel node biopsy is possible. Chemotherapy is to be avoided in first trimester and near to delivery. Otherwise, it's safe in second and third trimester. Avoid drugs like tamoxifen, trastuzumab, and methotrexate. They are teratogenic. Also, bisphosphonates. Radiotherapy is to be avoided during pregnancy and delay until postpartum. Plan birth 2 to 3 weeks after the last chemotherapy cycle because there is risk of neutropenia. Mode of birth is per obstetric indication. CS is reserved only for maternal or fetal indications. Breastfeeding from treated breast as such is not recommended. From contralateral breast is fine. MDT input is must. Preserve fertility if pre-treatment. Okay. Next comes the Mental Capacity Act. There are 5 statutory principles according to Mental Capacity Act 2005. Presume capacity unless proven otherwise. Take all practicable steps to help the person decide. Unwise decisions do not prove lack of capacity. Best interest for decisions made on their behalf and least restrictive option. Now let's look at this in detail. See, if any lady is presenting to you, then don't consider that she doesn't have mental capacity if she is not agreeing to any decision which you are giving. If you are counseling her for anything and she is not agreeing to that, don't presume that she is mentally not incapable. Presume capacity unless proven otherwise. And take all practicable steps to help the person decide. Means give her completely informed choice. Tell her all the benefits, risks, alternatives, and then allow her to decide. And it is not that if she is not deciding wisely, that means she is lacking capacity. Unwise decision doesn't prove that she is lacking capacity. And if you are taking interest in if you are taking decision in the best interest, then they are being made on their behalf if they are not able to take decisions. Or if they are age-wise not legally capable to give consent. And always try to take least restrictive option in their best interest. Okay? Means even if they are psychotic or if they are postpartum depression and you have to limit them, means restrict them, try to resort to least restrictive option. Another thing is 2-stage capacity test. Stage 1 is first you suspect, is there any impairment of mind or brain? If it seems to you that there is any mental impairment, then come to stage 2. Does it mean the person can't understand the information or can't retain it or can't use or weigh it appropriately or can't communicate her own decision? All 4 are needed for capacity. If any of this is lacking, then you can decide that yes, mental capacity is lacking. So, to conclude, capacity is decision specific, not global. A woman may have capacity for one decision, but not another. Regarding best interest decision, independent mental capacity advocate will decide if no family or friends are there. To take the best interest decision, IMCA will decide. Next comes court of protection. For serious medical decisions where dispute is still existing, court of protection will come into picture. Then comes very important slide regarding vaccination. Pertussis, this is standard UK pregnancy schedule, what and when to choose. Pertussis or whooping cough vaccine, preferably given between 20 to 32 weeks. Influenza inactivated, any trimester you can give during flu season for maternal and neonatal protection. COVID-19, again, any trimester, it is safe and recommended. New in 2024, respiratory syncytial virus vaccine has been introduced. It is to be given from 28 weeks and protects infant from severe RSV bronchiolitis. Tetanus diphtheria you can combine with pertussis, Tdap. It is given in standard schedule. Hepatitis B only if high risk. And inactivated vaccines are usually considered safe. Avoid live vaccines like MMR, BCG, varicella, yellow fever. They have got a theoretical fetal risk. If yellow fever is very much required and she has to travel urgently, then only it is to be given. Otherwise, yellow fever vaccine is avoided unless essential. Anti-D is in fact not vaccine. Routinely you give if RH negative to prevent isoimmunization. So this is regarding vaccination. Then FGM, although will be covered in antenatal module, the types: type 1 clitoridectomy, type 2 excision, type 3 infibulation, type 4 other. For FGM, if any lady you encounter, she is under 18 and has undergone FGM or she is about to undergo FGM, immediately report to police. It is mandatory to report within 1 month. Over 18, just safeguarding referral is required. FGM de-infibulation offer either pre-pregnancy or around 20 to 28 weeks or in early labor. Refer to specialist FGM clinic. Mode of birth, vaginal birth if possible. After de-infibulation, CS as such is not routinely indicated unless and until obstructed labor is happening because of de-infibulation. FGM birth registration, complete FGM information sharing system, HSCIC dataset you have to record without anonymization. Why? You have to specify the details so that data doesn't get duplicated. Then comes domestic violence. HARK, humiliation, afraid, rape, kick. This is a single screening question which is used to identify domestic violence patients. Safety planning is very much essential. If you are suspecting any lady to be suffering with domestic violence, don't let her go without safeguarding referral. Always document, do a safeguarding referral, involve this domestic violence abuse agency, women's refuge, and even you can involve police if it looks that she is at risk of immediate threat. Then there may be other complex social factors like asylum seekers, refugees, homelessness, substance misuse. You have to deal accordingly. Maternal sepsis and domestic violence are especially higher in those who are late bookers, missed appointments, poor outcomes. So if in your scenario question, it is given that she has booked late or she is getting late for her follow-up visits, she is missing her follow-up appointments, be on the lookout for these complex social factors. So just some pearl points. Never use tamoxifen, trastuzumab or methotrexate in pregnancy. Never give live vaccines. Never assume capacity is lost if any person is refusing the treatment which according to you is correct. Never ignore FGM in under 18. Police reporting is mandatory. Never discharge any domestic violence disclosed woman without safety net or safety plan in place, and try not to give gadolinium MRI contrast in pregnancy. Always do mammogram or ultrasound plus biopsy if breast lump in pregnancy. Pertussis vaccine, you can give between 20 or 16 to 32 weeks. Influenza, give any trimester. Apply a Mental Capacity Act 5 principles plus 2-stage capacity test. Refer FGM under 18 to police. Always Do HARC screening if at any time there is any suspicion of domestic abuse, IDVA referral, and safeguarding. Sentinel node biopsy you can do. Radioisotope is safer than blue dye. Top one-liners: pertussis, flu, RSV, avoid by live vaccines, MCA and FGM under 18. Okay. Then cross-cutting drug safety atlas. Again, just have a look. Lamotrigine, levetiracetam are preferred and safe. Sodium valproate not safe. Hydroxychloroquine you can continue. Methotrexate and mycophenolate switch to safer drugs. Anti-TNF infliximab is safe. However, live vaccines to be delayed 6 months in babies. Sertraline is the preferred SSRI and first-line drug for breastfeeding in depression women. Lithium, there is risk of Epstein's, hence specialist appointment is essential. Avoid in breastfeeding and carry out fetal echo. Tamoxifen teratogenic, trastuzumab, risk of oligo is there, hence avoid. Okay. This again, master recall trap sheet, sodium valproate plus planning pregnancy. Switch to lamotrigine or levetiracetam preconception. Mechanical valve on warfarin 6 mg plus pregnant. So switch to LMWH with anti-10A. Sickle crisis plus analgesia. Morphine you have to give, not pethidine. Bile acids more, then deliver by 36 weeks. AFLP tried, hypoglycemia, coagulopathy plus high ALT, Swansea criteria, urgent delivery. Hydroxychloroquine in SLE pregnancy, continue, don't stop. Anti-Ro positive at 18 weeks, fetal echo for heart block. Live vaccine in baby exposed to anti-TNF, delay 6 months, sepsis 6 timeline, Hg plus IV dextrose given, Wernicke's risk, DK, glucose 9 in pregnancy, maybe euglycemic, maternal collapse, more than 20 weeks, 5 minutes, no return of spontaneous circulation, do perimortem CS, postpartum psychosis, day 8, recommend MBU admission, recurrence risk is 50%, FGM under 18, mandatory police reporting, and pertussis vaccination is ideal between 30 to 32 weeks. This is to be remembered. WHO 4, class 4, avoid pregnancy. PPCM already we dealt with. Sickle aspirin, LMWH, penicillin prophylaxis is a must. These are the thresholds of anemia in pregnancy. ICP, if it is more than 100 levels of bile acids, plan birth by 35 to 36 weeks. Hydroxychloroquine can be safely given. Stop these drugs. Valproate not to be given. Sertraline is the first line SSRI. Postpartum psychosis, MBU admission, sepsis 6 in 1 hour. And all these we already read repeatedly. So hope it's all stuck in your minds. Now to finish with, as we are in the last 5 to 10 minutes of our class, let's do a quick recall of rashes in pregnancy. The first thing is very important is chickenpox. The rash pattern is usually vesicular. They happen to grow in crops and are often itchy. Key clinical clue is fever and vesicles will be there in different stages. Peak fetal risk is in early pregnancy. Fetal varicella syndrome, however, incidence is just 1%. Urgent action, as we all know, if any lady is exposed to chickenpox case, we give acyclovir as post-exposure prophylaxis after 1 week. VZIG within 10 days of exposure. If acyclovir is not feasible, then acyclovir is given as treatment if rash, ladies presenting to you with rash within a week, and especially if she is 20 weeks or more. HSV, genital herpes, rash is again vesicular, but pain is very prominent. Often the lady presents with urinary retention, so it is very much suggestive of herpes. So painful genital lesions points towards herpes, along with dysuria, tender lymph nodes might be there. One very important percentage is this 41%. So if primary HSV infection is happening in 3rd trimester and you allow her to deliver vaginally, then the risk of neonatal HSV is very high, around 41%. The drug of choice, we all know, whenever the patient presents with fresh episode, whether primary or recurrent, give acyclovir for that week. And then suppressive acyclovir start from 32 weeks. And if primary episode is happening anytime near term or even in third trimester, prefer LSCS as the mode of delivery. Parvovirus B19, there is reticular or lacy pattern of rashes with a slapped cheek appearance. In adults, arthralgia may be there. In child, slapped face cheek syndrome is there. 9 to 20 weeks, there is maximum risk of hydrops, 3%. See, parvovirus is one virus which is not teratogenic. It just causes hydrops. Parvo can be diagnosed through IgG, IgM, serial ultrasound plus MCA-PSV because it might lead to anemia, fetal anemia. Hence, MCA-PSV is the test of choice to diagnose anemia, fetal anemia. Then rubella. Rubella is very teratogenic, especially if it is occurring in first trimester. Maculopapular pink rashes fades fast. Suboccipital lymphadenopathy may be there. At less than 12 weeks, congenital rubella syndrome, the chances are very high for the fetus to get infected. Hence, if fresh rubella is happening to the lady in first trimester, counsel for termination. The triad of congenital rubella syndrome is sensory neural deafness, congenital heart defects, and congenital cataract. We diagnose through IgM, IgG, and postnatal MMR is advised if she remains susceptible. Then comes measles. Morbilliform rashes are there, cephalocaudal. Koplik spots are diagnostic pathognomonic of measles, plus cough, coryza, and conjunctivitis. If it is happening in adults, maternal pneumonia chances are high. Now, if any lady, susceptible lady who has not been immunized with MMR, she is not immune to measles. If she is getting exposed to any measles case, give her human natural immunoglobulin within 6 days. Okay, HNIG, give her within 6 days of exposure. All right, and notify. Then Zika virus, maculopapular and pruritic rashes, travel history is there, non-purulent conjunctivitis. In first trimester, it may lead to microcephaly. Test via rare and imported pathogen lab. This is one kind of lab which is there, rare and imported pathogen lab. Test Zika virus there and carry out serial ultrasound scans for development of any anomalies or fetal growth restriction. Coming to syphilis, palmar or plantar rashes, copper colored, painless ulcer history will be there generally with condyloma lata or not, plus minus. Throughout pregnancy, fetal risk is there, especially in third trimester. Benzathine penicillin is the drug of choice. We give doses decided according to trimester. Then comes congenital CMV, petechial and blueberry muffin rashes. What symptoms mother usually might present with no symptoms, or if symptoms are there, they are just like glandular fever or infectious mononucleosis like symptoms like fever, malaise, joint pains, lymph nodes might be enlarged. And in neonate, jaundice, congenital deafness may be there. Hepatosplenomegaly is often observed. First trimester, primary fetal risk is there. Here, IgG avidity test is done. Avidity test means if the avidity is low, then the infection is recent. If the avidity is high, infection might be old. So, IgG avidity test is especially important in CMV. Valacyclovir may be given to reduce the risk of transmission. Next comes GBS, petechial plus unwell baby, early onset GBS infection less than 7 days. Respiratory distress might be there, intrapartum exposure, whole GBS guideline. In fact, it has been given when you have to give intrapartum antibiotic prophylaxis wherever membranes have been ruptured and she's a known GBS carrier or has had GBS bacteriuria in early pregnancy or previous baby has been affected, then there are very high chances of GBS. So we give intrapartum antibiotic prophylaxis, neonatal antibiotics, and sepsis screen. And last is the drug eruption. Hi, Dr. Soumya ma'am. I'm seeing that you are raising your hand. I'm in fact on the last line of my presentation. Drug eruption is often variable, often morbilliform rashes. Recent new drugs, if they have been started, might present with drug eruptions. So the main thing here, urgent action will be stop the drugs and resort to supportive care. So vesicular rash, both need PCR ulcer panel, PZV or HSV, are usually present in the form of vesicular rashes. Maculopapular rash, generally parvo, rubella, measles, Zika, drug, they present as maculopapular rash, test in parallel. And always in any rash, do booking bloods and fetal medicine referral if it is confirmed. So that was uh, the whole presentation of maternal medicine, the remaining modules. Dr. Soumya ma'am, are you there?
Yes, Swati, I'm here. I just joined like probably few minutes before. Guys, thank you so much for all the fantastic feedback which we are receiving. And you could see that mentors are putting a lot of effort, and I've worked a lot on these presentations. I'm happy that it is helping all of you. And I think Swati has to close down our clinic to be here. So thank you, Swati, so much for the same.
Always
And
welcome.
guys, what we expect is a feedback forms to be filled in. And this is just the beginning. I wanted to start with the metal medicine because that's a bigger deal. So you guys should be happy about managing the things. And 100% we are going to make your life easier in the coming days. Thank you, Swati, once again. And thank you, everyone, for
Yeah.
attending these sessions with so much of enthusiasm and attendance. Thank you, guys. Thank you, Swati. Thank you once again.
Thank you. Thank you so
Thank you,
much,
Sudha.
ma'am. And thank you, everyone, for patient listening. And again, we shall be meeting tomorrow for labor and delivery module. So, all the very best. Bye bye. Hope you like the session. All the very best and happy studying, guys. Bye bye.